All right. Hi, everyone. We're going to get started. Welcome to our 2026 APAMSA ICU Bootcamp. Thank you all for being here, and thank you also to our speakers for taking time out of their busy schedules and Sundays for being here. This is our first ICU Bootcamp. We've been hosting the Bootcamp series for a few years now, but it's our first time doing ICU, so we're really excited to be able to bring this to you guys. And Daniel, if you can advance to the next slide. We've had 11 boot camps this year. This is our second to last one. So we have internal medicine in a few hours if you're interested. And the rest of the boot camps will be available uh, on our YouTube in a few weeks. So you can look back at those if you missed them. And I will turn things over to Victoria.
Thanks, Kelly. My name is Victoria Sigielski. I'm part of the National APAMSA Alumni Board and a former national board member of APAMSA, and I'm very excited to welcome you to National APAMSA's inaugural, as mentioned, ICU Anesthesia Boot Camp, which is our 10th boot camp series, boot camp in the boot camp series this year. And today's ICU Bootcamp is aimed at providing high-yield tips and approaches to commonly encountered scenarios in the field. I'd like to thank our amazing panelists, Doctors Wang, Su, and Wu, for preparing this fantastic bootcamp. And I'll now hand it over to Daniel to orient you to today's format.
Hi, everyone. Once again, welcome to the first ever National APAMSA ICU Bootcamp. Just a quick introduction to myself. My name is Daniel. I'm the anesthesia lead for this year's National APAMSA Student Subspecialty section. We have a very exciting presentation, a very thorough presentation covering ICU fundamentals today, prepared by Dr. Wu, Dr. Su, and Dr. Wang. Before we begin, just a few quick notes about audience participation. First, in order to facilitate the learning process, in general, we want this to be as active and as engaging as possible. And so to that end, please do not hesitate to leave any questions you have in the chat. The chat will be monitored by the other speakers who will do their best to promptly answer any questions you have. In addition, also, please feel free to raise your hand if you have any questions and you want to verbally ask them. And if you do so, just briefly introduce yourself and go ahead and state your question. I think we will try to leave time for questions. We will try to accommodate questions at the end, but that really does depend on whether time permits. So again, in general, we invite your active participation during the session itself. Cool. With that in mind, let's proceed with some speaker introductions.
Hi, everyone. My name is Chelsea Wu. I am originally from Phoenix, Arizona. I did my med school at UT Health San Antonio, and I just did my internal medicine residency, completed it last year at Baylor College of Medicine in Houston. I'm doing like a hospice year, so I'm actually working as a nocturnist in one of the hospitals in Houston, actually in the ICU specifically. So it's kind of a unique role, and hopefully I can provide some insight from my experience there. But I will be starting my Poem Crit Fellowship this July. So I'm excited for that. And then outside of work, I like to read and write and try new foods and recipes. Honestly, I'm not that exciting outside of work. But yeah, that's me in a nutshell.
Hey guys, I'm Will. Grew up in New Jersey. Went to med school at UT Southwestern Dallas. Did residency and fellowship at Johns Hopkins. I did anesthesia and critical care. Um, Things I like to do outside of work. I love cooking and baking, going out, trying new restaurants, and watching anime. Uh, got through a lot of One Piece on calls. So
Hey everyone, I'm Anke Wang. I grew up in Hershey, Pennsylvania. By training, I'm an anesthesiologist, so I went to med school at Albany Medical College, and in terms of residency, did my intern year at Bassett up in Cooperstown, and then the 3 years of anesthesia at NYU. My path is a bit more similar to Dr. Wu, where after finishing residency, I worked as a general anesthesiologist for a year, and then now I'm back in fellowship at Duke for critical care. Outside of work, I'm also not that exciting at the end of the day. I like to read a lot, not much what I call adult books or like nonfiction stuff. It's just a lot of like romance, fantasy, escapism. And then other than that, I like to pick things up, put them down, try to make new food, fail, and then decide to find new restaurants to eat at. So that's kind of me.
All right, so we have a lot to get through, so we'll get started. So the first thing I want to talk about is, this talk is mostly tailored to incoming interns or medical students. So it's really how do you round and then present in the ICU. So the whole focus of rounding is really you have a really big team. You have the attending fellow, residents, you have your pharmacist, you may have your RT. So what you want to do, the whole point is to really direct the whole team on what the problems are and how are we going to make real-time decisions to handle those problems. Now, not a lot of times where I see people get tripped up is there's a ton of information and they have a really hard time sorting through it. So my tips for incoming med students or interns is to really, for the first week, just come in early. Come in early, really take the time to learn your medical record. There's a ton of information out there, and talk to the seniors or the fellows on how to organize everything. Usually, like for example, I use a lot of Epic, so there's a bajillion tabs you can have, but I only use about 10. So come in, figure out what those high yield tabs are and the information you can get from them. Another thing I really recommend is having a checklist. Just as an example, right? Like if you're going through neuro on your assessment plan, right? Okay, what are the pain meds they're on? What's their mental status say, and just have that all ready to go. Otherwise, you're kind of fumbling around with your presentation. And the last thing is really, these patients are really complex in the ICU. They've maybe been in the hospital for a long, long period of time. It's really to just this is the time to really learn how to summarize patients in a succinct way, and then really focus on the things that matter. And a couple of other things I really want to point out are, in the ICU, things are really dynamic. Things change on a minute-to-minute basis. A lot of times, if you look at the vitals outside the door, they look great. But that's because we can make them look good. Nurses can go up on pressors, they can go up and down. So you really don't know what's going on unless you're bedside often. And a lot of times the nurses, they'll change things, but they won't always put it in the chart yet. So I always recommend to my med students and residents, really be bedside often, because things can change without you really knowing. And another thing, I think this is probably the most important thing, is really take the time to build a rapport with the nurses. They are our constant eyes and ears in the unit. And as an attending, I usually sit with the nurses at the nursing station. And so I hear all the complaints about the residents. So I would say, if the nurse contacts you about some sort of issue, come to bedside, talk to the nurse, assess the patient together, and always validate the concerns, even if you're not too concerned, but at least validate them and come up with a plan together on how to handle it. Next slide. And so when you're presenting during rounds, this is really depending on your institution, there's going to be different structures, but this is the one I think I've come across most often, both in my med school, my intern year, and my residency. So you're always going to start out, just like in medicine, with a one-liner. And this is the time to really try to summarize the patient well. Include why they're admitted into the hospital, why they got upgraded to the ICU, any pertinent medical history. And I always like for my residents to tell me what's their current ICU indication, because at the end of the day, we're trying to get them better to the point that they can leave the ICU. And so we need to really focus on why they're here in the ICU specifically. And then I just like to have my residents go through basically the SOAP part. So your subjectives, any important overnight events. And I usually really only care about like the really critical ones, like patient get intubated, patient got started on pressors, patient was massively transfused, patient went to the OR. Things that are really, really important. Because what you don't want to do is you don't want to be redundant and then keep saying the same thing over and over and over, and then your presentation runs for 20 minutes. Then you have your objectives, so physical exam. And what I always tell my residents is, please provide context for, your vitals. The SAT is 99. Well, is that because they're on 100% FiO2? So you have to provide context to the vitals, because especially in the ICU, we have a lot of ways we can make numbers look better. And then in terms of the assessment and plan, really depends on your institution, but from what I've seen, a lot of people like to go through a system by system basis. And so usually we'll start with neuro, like head to toe sort of assessment, and then we'll end with our ICU checklist. And so we kind of structured this whole presentation based on these different organ systems and going through them. Next slide. So to start off at the head, so neuro in the ICU, I think pretty high yield things I want to talk about today are delirium, your analgesia and sedation options, and then we'll end on a topic that can be is a medical emergency and involves different sedations. Next slide. So what is delirium? So delirium is an acute disturbance in attention and awareness that develops over a short period. Key thing is it fluctuates in severity, so that's a waxing and waning, and it comes with cognitive impairment. So how do we screen for delirium in the ICU? So this is a term you'll hear a lot. It's called CAM ICU. Basically, it's our simple screening algorithm. It's very, very simple. The nurses usually do a very good job of documenting whether a patient is CAM ICU positive or negative. And so if they're positive, they have a really high chance of being delirious. The specificity is 95 to 96%. In terms of working through it, next slide, please. So what you're first going to look at is, okay, is their mental status an acute change, and or is it fluctuating within the last 24 hours? If they're totally fine and they don't have any waxing waning, well, they're CAM negative. The next thing is to look at whether they have inattention. And sometimes you can just pick this up by talking with the patient, if you're talking with them and they just can't seem to stay focused, they're being inattentive. But if you can't tell, sometimes what you can do is you can do a simple test. One of the examples is, just squeeze my hand every time I say the letter A, and you just say a bunch of different letters. If they're following, they're attentive. They're not, they're inattentive. And then the next step is looking at their level of consciousness. In the ICU, we like to use something called a RAS score. We'll talk about that next. But that's basically assessing their it's agitation sedation scale is what the RAS is called. And if they're agitated or they're very somnolent, then they would be put into the CAM ICU positive. If they're calm and paying attention to you, then you want to think about, okay, do they have any disorganized thinking? Next slide, please. So this is another thing we'll often talk about in the ICU. It's their Richmond Agitation Sedation Scale. This is, what we use to describe patients, whether they're agitated or they're very sedated. And it's another thing we use to assess, if we're overly sedating somebody or not sedating them enough. And so it's something you'll see very commonly. So a RAS of 0 just means that they're calm and they're paying attention to you. And a positive RAS would mean they're agitated. A negative RAS means they're overly sedated. Next slide. Okay, so why do we care about delirium so much in the ICU? Well, time and time again, it's been shown to really um, worsen outcomes. And it increases ICU length of stay because they're getting sedatives if they're very agitated or they're not participating in care. It increases mortality. Um, and you have all sorts of other problems, including pressure sores. Patients are at risk at having hospital-acquired infections, et cetera, et cetera. And in terms of delirium, you really have two kinds. You have a hyperactive delirium, and then you have a hypoactive delirium. With a hyperactive delirium, these are the patients who are more agitated. And then the hypoactive delirium, these are ones who are more somnolent. They're not really paying attention to you, et cetera, et cetera. Next slide, please. So this is a really, really big topic in ICU these days. It's this sort of bundle we've created to try to reduce delirium in the ICU because a lot of things in the ICU, that we do in the ICU can cause delirium. And so it's called the A, B, C, D, E, F bundle. You'll probably hear about this a lot. So A is about assessing and preventing and managing pain. B is doing a SAT, which is a spontaneous awakening trial, and SBT is a spontaneous breathing trial. C refers to the choice of analgesia and sedation. D refers to assessing delirium, so doing the CAM ICU score, and then doing things to try to prevent it, like turning off the lights at night, frequent reorientations, etc. E refers to early mobility and exercise, and F is family engagement and empowerment. And so they've shown through studies that if you incorporate this A, B, C, D, E, F bundle, you really reduce mechanical ventilation duration, you reduce ICU length of stay, and you reduce mortality. And you don't even have to follow it perfectly. If you follow it about 50% of the time, then you still have really, really improved outcomes. Okay, next slide, please. So next thing I wanted to touch on was analgesia and sedation. So the way I like to think about this is I like to separate them. So you have your analgesia for pain, and then you have your sedation for agitation. And the way we like to approach this, it's very simple. First thing we always want to do is we always want to treat pain. Then we want to think about sedation. So pain is a big contributor to both delirium and agitation. If your patients are in pain and you're not properly treating it, they're going to go crazy. And it's just like a terrible, feedback loop that just leads into a whole bunch of trouble. So once I know, or once I think my patient has an adequate analgesia, then I want to think about, okay, do I need to give them any sedation? A lot of times you'll see patients may not even need sedation. And our goal is always a RASS of 0. So a RASS of 0 is someone who's awake, calm, paying attention, not having any issues. Okay, next slide, please. So I just wanted to show you guys this picture. So this is an example of what we call a walking ICU. So I think the misconception that a lot of people have is that, when patients are intubated, they have to be really sedated for them to tolerate the ventilator. Well, this is not true. If you adequately control their pain and you talk with your patients and orient them, then you can have patients like this. Picture on your left, patients walking around the ICU on a ventilator, patient on the right, playing an instrument on the ventilator. Both these patients are not heavily sedated. So it is possible. Next slide, please. So again, this is kind of the algorithm I use to think about how I manage pain and sedation in the ICU. So first thing is to always think about, okay, is my patient in pain? How do I treat that pain? Pain's treated. Now I can think about sedation. And there's only really a few indications for really deeply sedating somebody. One of them is seizures. The others, ventisynchrony. So if the patient's fighting the ventilator, then you may need to sedate them heavily so they don't find the ventilator and harm themselves. Others are, elevated intracranial hypertension. You want to lower the ICP levels, so you got to sedate them heavily. And the others are, if they have an open surgical abdomen. Next slide, please. Okay, so assessing, preventing, and managing pain. So if you guys go to the internal medicine lecture later today, they'll talk a little bit more about this, so I'll just quickly go through this. So there's different ways to assess pain. Usually if the patient can talk, you can ask them what kind of pain are you having, scale of 1 to 10. A lot of times we can't, so we got to rely on other things. The nurses will use a behavioral pain scale, or another scale is called the Critical Care Pain Observation Tool, CPOT. But one thing I really want to point out is that vital signs are not a good validator of a patient having pain. You can be in pain and have totally normal vital signs. So don't use it as like, oh, their vitals are okay. They're not in pain. And then you want to think about ways to be proactively preventing pain, giving local for your, line placements, even if they're sedated, or giving PRNs, et cetera, et cetera. And then managing pain, you always want to have a focused, PRNs or scheduled meds to tackle pain. Next slide, please. And the way we want to treat pain in the ICU is we want to use a whole bunch of different types of medications. We call it multimodal pain control. So you don't really want to just rely on your opioids, because that can lead to respiratory depression. It can lead to slowing of the gut, and it can lead to opioid dependence. So a whole bunch of problems. So these are kind of the different options you have. I think the internal medicine lecture will go a little bit more in depth there. Next slide, please. Okay, so these are kind of the main medications we use in the ICU for sedation. And the first three I've kind of highlighted in a darker blue, because these are the ones where you can really use to get somebody into like a general anesthesia state of sedation, or really a RASS -4 to -5. So these are the three medications that you can really use to put somebody down. Common ones you'll see, so propofol is one we use in anesthesia a lot. The real pros of it are it's fast on, fast off, easy to titrate, great for neuro exams, and you can really put someone down with it. So your cons with it, it can cause hypertension, hemodynamic instability, and then you kind of have these other issues if you're running it for a long time. One of them is a syndrome called propofol infusion syndrome. This usually presents as cardiac failure, rhabdo, and multi-organ failure. It's pretty rare, usually seen in kids only, but it's something that can happen. Another issue is propofol, has lipids in it. It's that white, solution. So you can get hypertriglyceridemia, and then you also, that can also lead to things like pancreatitis, etc. So that's propofol. Your next main drug that if you need to put someone really down is midazolam. So midazolam is a benzo. The real benefits of it are it's hemodynamically stable. It's non-QT prolonging, like many of our sedating meds. So if you have someone in the cardiac ICU, who's having issues with QT prolongation, this is a medication you can choose. But what are the main issues with it? Well, the main issue is it causes delirium. It's probably one of the highest predictors of a patient having delirium is if they've been on benzos, especially a benzo infusion. It's also been shown to really prolong ventilator days. And another thing is, as a benzo, patients can develop a dependence on it. The next medication that you can really use to put someone into a RASS -4 to -5 is ketamine. The real benefits of it are it's not a respiratory depressant. It's a really good bronchodilator, so if somebody has really bad asthma. The real issues are that it can cause unpleasant dreams, hallucinations, increase secretions, and it can make you tachycardic, make your blood pressure go up, and it can also raise your intracranial pressure. So those are the three that you can use to really heavily sedate a patient. Now, the next two are sort of what I like to refer to as sort of your step-down medications. So if you have a patient that comes in, they really need to be sedated, you'll choose either propofol, midazolam, or ketamine. Usually it's propofol. But then once you're lightening up the sedation, you can switch to one of these sort of step-down medications. The big one we use a lot these days is dexmedetomidine. It's an alpha-2 agonist. What's really nice about it is there's no respiratory depression with it. It sort of encourages a natural sleep cycle. And so there's some belief that it could be beneficial for delirium. Sort of the issues with it, again, you can't really heavily sedate somebody with dexmedetomidine, and it can cause bradycardia and hypotension. Another medication we'll frequently use in ICU to kind of, as a step-down medication, are these antipsychotics. Again, they're really good for severe agitation. You can't put anyone into a RASS -4, -5. Frequent one we use is Seroquel. And the main sort of con is it's very QT prolonging. Okay, next slide, please. And so this is just an example of how you would wean sedatives. So if you had an example, for example, an 18-year-old who presented with severe TBI after a skiing accident, and you had to heavily sedate them for their elevated intracranial pressures, well, you may start with something like midazolam and a Dilaudid infusion. Once you feel like the ICPs have decreased a little bit, you may switch from midazolam to propofol, your hydromorphone to fentanyl infusion. And then as you continue to de-escalate, you can switch your propofol to a Precedex infusion, and then you can switch your fentanyl infusion to either lower it or add scheduled oxys. And then eventually, once the patient is more participatory, you can continue the Precedex, maybe add a little bit of antipsychotics like Seroquel for agitation, and then you can switch to a PCA where the patient can control their own pain meds through a button. Okay, next slide, please. So I just want to briefly touch on a sort of real neuroemergency, delirium tremens. So this is something that can happen with a patient who has severe alcohol withdrawal. Usually happens within days 2 and 4. Usually presents extremely delirious, confused, agitated, with autonomic hyperactivity. They're tachycardic, hypertensive, febrile, and they've been given benzo after benzo and benzo without any effect. And again, so alcohol withdrawal is due to a GABA downregulation. So remember, GABA is an inhibitory neurotransmitter, and then they also have an NMDA upregulation, or the glutamate pathway, which is excitatory pathway. And so, as with all things in life, if you're giving something again and again and it's not working, try something else. So for these patients, usually they warrant an ICU admission because we're going to heavily sedate them, and so that may lead to respiratory depression or other issues. In terms of other medications, so they've been given benzos. Now you want to try switch. Sort of the first line you can use is phenobarbital. So phenobarbital, the sort of pros that it has is it can directly open GABA receptors, unlike benzos. The issue is phenobarbs have a really long half-life. So if you start loading somebody, you're kind of stuck with the consequences for the next few days. The other option is you can put somebody on propofol. So again, propofol acts on a different site than the benzos. It's short acting, but the real issue is, most places, they won't let you run a propofol infusion because of the respiratory depression, unless they're intubated. So these guys got to get intubated. And that can lead to longer ICU length of stay and mechanical ventilation time. And then you can add Precedex and the antipsychotics, but these don't really treat the issue. They just kind of help with the agitation. So I think that's it for neuro.
Great, thanks, Dr. Su. So now I will be going over the respiratory issues that you may run into in the ICU. So this section is a little bit longer, but just bear with me for now. So we'll discuss kind of different oxygen delivery modalities. We'll talk about mechanical ventilation, and then we'll kind of go over some common lung diseases you might see in the ICU, and then go over some respiratory emergencies. Okay, next slide. So to just kind of have a basic framework for everyone, I wanted to just talk about, what are our oxygen goals in the ICU and how do we even monitor oxygen levels? So you might have all seen like SpO2 monitors or pulse ox monitors. You can do this in the outpatient setting on any floor and in the ICU. And what that's measuring is the percentage of oxygen carrying hemoglobin in the blood. So we like to keep these numbers generally above 90. You generally don't want to hyperoxygenate patients. So honestly, 90 to 96 is usually a pretty good saturation. And then for our COPD patients, we like to keep that between 88 to 92%. In the ICU, you might see more arterial blood gases being ordered, and what that's measuring is the PaO2. So that's different than SpO2. It's measuring the partial pressure of oxygen that's dissolved in arterial blood. So those numbers will be different. Those goals will be different as well. In general, I like to say anything between 55 to 70 is good. And just as like a ballpark, a PaO2 of 60 is equal to about an SpO2 of 90%. Okay, next slide. So how do we reach those oxygenation goals? There are a multitude of different oxygen delivery modalities that exist now. I'll just kind of go over the basic one, just so we kind of have an idea of how we can escalate oxygen delivery mechanisms. The one you've probably seen the most, and for patients who are maybe a little bit hypoxemic on room air, is just nasal cannula. So this is just small nasal prongs that's connected to wall oxygen, and it can deliver usually up to 6 liters of flow per minute. For flow, you can estimate that every liter of flow gives you about 3 to 4% of FiO2. So it can give you about up to 45% of FiO2. If patients are still a little bit hypoxemic on nasal cannula, you can escalate them to more large bore nasal cannula. In my hospital, we call this high flow nasal cannula as well. It's just larger tubing and also connected to the wall, and you can go up to 15 liters per minute, up to 80% FiO2. Some patients don't tolerate nasal cannula. They may get nosebleeds. They may be like more mouth breathers, and you can give them a simple face mask, which I didn't show here on this chart. There's also a Venturi mask, which is a special type of face mask that has these little different color-coded adapters that are put on there, and that just indicates different FiO2 levels. The next one I have here, the fourth one, is a non-rebreather mask. So I usually reach for these only when patients are more like acutely hypoxemic and we want to get their oxygen up a little bit faster. It's more a little bit readily available than other forms of oxygenation sometimes. So this is basically a face mask that's connected to a reservoir bag that provides 100% oxygen. There's a one-way valve on it, so you're not inhaling that CO2 that you're exhaling. This is also connected to the wall, can provide up to 15 liters per minute and can provide up to like 90, maybe 100% FiO2. Let's say can you go back? Let's say you have patients on non-rebreather, you're trying to transition them off to something else. You may consider transitioning these patients to like a heated high flow nasal cannula. There's different brand names for it. You may have heard of Vapotherm or Optiflow, but what's really nice about this machine is that it delivers a really high flow rate. So some machines can go up to 60 liters per minute. It provides heated air as well as humidified air. And because of the high flow rate, it actually provides a little bit of PEEP. So we like to say maybe 10 liters per minute is equal to about a centimeter of water of PEEP. And then you can adjust the FiO2 up to 100%. So even though it's not a ventilation assistant device, it can also help clear out a little bit of CO2 in the dead space. So sometimes I use it in patients who are a little bit hypercapnic, but maybe don't, won't really tolerate BiPAP mask or anything like that. So I might start with this first. Next slide. So this is just kind of pictures of what all these oxygen delivery devices look like, from nasal cannula on the top left, face mask, a Venturi mask, the non-rebreather. On the bottom left, this is heated high flow nasal cannula, and this might be what the machine looks like. This is a vapotherm, so it shows like the flow rate and the FI2 as well as the temperature that we're setting. And then on the bottom right are just different kind of BiPAP and CPAP modalities, which I'll talk about next. Next slide. Okay, so next we'll talk a little bit about non-invasive ventilation, mainly like CPAP or BiPAP. These modalities can help reduce the need for intubation in certain patients. Its main indications are honestly for COPD and heart failure exacerbations, but you can use it in patients who have some neuromuscular disease and some weakness. You can use it for patients who have increased work of breathing, who have some hypercapnia and hypoxemia. There are contraindications to non-invasive ventilation. If a patient's very altered, they're not protecting their airway, they should probably just proceed to intubation, and we shouldn't really use a non-invasive ventilation to see if they would tolerate that. If they have a lot of excessive, or if they have a lot of facial trauma, putting positive pressure on their face is not going to help, so that is contraindicated. And then if they're actively vomiting, if they have lots of copious secretions, the mask can just increase their risk of aspiration. So I would definitely avoid it in these patients. Next slide. So I'll talk briefly a little bit about CPAP, which stands for continuous positive airway pressure. In these machines, you generally just set one single pressure, which is the EPAP or the expiratory pressure. Generally 5 to 8 is a good starting place, but you kind of titrate based on the patient. Its primary indication is actually in cardiogenic pulmonary edema in the hospital setting. It can reduce mortality in those settings by increasing intrathoracic pressure. You can reduce the preload, so reducing some of the venous return, and then you can reduce some of the LV afterload. So you can see that kind of helps the heart pump a little bit better and helps reduce some of the pulmonary edema. In patients who have refractory hypoxemia, it can help splint open the airways a little bit to help with that. But an important note, CPAP does not assist with ventilation. So we'll contrast this next with the next slide, BiPAP, which is a machine where you set 2 different pressures, an EPAP, an expiratory pressure, and an IPAP, an inspiratory pressure. And that difference in the pressure is a pressure support or a driving pressure that allows and provides for ventilation. So these are really helpful in patients who have, acute hypercapnia. Its main indications are really in cardiogenic pulmonary edema as well, but also in COPD exacerbations. It can help reduce the need for intubation in those patients. And then you may see patients who have obesity hypoventilation syndrome, who are a little decompensated and they're hypercapnic as well. So it's really helpful in those patients. Like I said, you can use it for patients who have neuromuscular weakness, who have hypoxemia or hypercapnia for other reasons, but it's not really necessarily indicated for those. So I would keep definitely a closer eye on those patients in case they need to be intubated. Next slide. So this is just an example of maybe what a screen for a BiPAP might look like. On the bottom, on the left hand corner, you can see the red boxes surrounding. There's an IPAP, there's an IPAP of 10 that's set, and an EPAP of 4. And then on the top is kind of what the patient is doing. So that red box up there is their tidal volume. So this patient is breathing 316 cc's. Their minute ventilation on the right, which is respiratory rate times tidal volume, is 3.8. So you can see this slide is pointing out that their minute ventilation is honestly not great. So something to just keep an eye on. If you make any changes to the IPAP or the EPAP, you generally want to see changes in the patient's tidal volume or their minute ventilation. If you're not seeing changes in that, your gas numbers are probably not going to look any better. So just to keep an eye on in case you need to set up for intubation for these patients. Next slide. So, let's say you try to oxygenate these patients, they're not oxygenating well, et cetera, they need to be intubated. So we'll talk a little bit about mechanical ventilation next. So the indications for mechanical ventilation, we obviously have hypoxemia, hypercapnia, impaired airway protection. So patients who are very altered, not breathing normally, if patients are actively seizing, we need to put them on more sedating medications. If patients have anaphylaxis or laryngeal edema, these are all indications for mechanical ventilation. If patients have some sort of neuromuscular disease causing diaphragmatic weakness, for example, like myasthenia gravis, GBS, and then if they're having respiratory distress, so if patients have some are in septic shock, have really high metabolic demands, and they're just not able to keep up with it, we may put them on the ventilator just to decrease that work of breathing. So our goals with mechanical ventilation, the obvious ones are oxygenate, ventilate to decrease the work of breathing, but it's also important that we maintain patients' comfort on the ventilator. Like Dr. Su mentioned, uncomfortable patients will lead to more delirium. And then ultimately, mechanical ventilation is not really an end goal. Ideally, the day we intubate a patient, we want to figure out how we're going to liberate them from the ventilator. And if we're not able to, we'll have to discuss things like tracheostomy. Next slide. So this is just an example of maybe what a vent looks like. I think part of the scary thing about being in the ICU is that there's just so many machines and there's so many numbers and things that you're looking at. I would say every hospital, different hospitals have different ventilators. This one is a Puritan Bennett ventilator, which is what my hospital uses. Unfortunately, they're actually not being manufactured anymore. But I would say day one of your ICU rotation, try to familiarize yourself with the vent. Try to ask your senior, the respiratory therapist, your attending, if they have time to kind of just walk you through what you're looking at. So I just wanted to walk you guys through what kind of you're looking at here. So this ventilator, on the bottom left corner, there's a red box circling something called ACPC. So that tells us the mode of ventilation. For this one, it's assist control, pressure control. Then we have here, actually, are you guys able to see my mouse? Let me see. Here, we see the respiratory rates, 12. So that's the rate that we're setting for the patient. Here we have the inspiratory pressure that we're setting for a patient, which is 10. We have an FiO2 on the oxygen that we're providing, which is 30%, and then the PEEP, the positive end expiratory pressure, is 10. So these are the settings that we've set for the patient. So on rounds, you might say that the patient is on ACPC, getting a rate of 12, an inspiratory pressure of 10 with a PEEP of 10 and an FiO2 of 30%. And then on the top for this specific ventilator is what the patient is doing. So this red box here, this is the tidal volume that the patient is generating based on the settings that we set. So they get a tidal volume of 411. Their respiratory rate is 18. So you can see they're breathing above the machine rate that we've set. And then their minute ventilation is here, 7.36. So again, just something to familiarize yourself with. And I think as you see more ICU patients, this will become a little bit easier. Next slide. There are different modes of mechanical ventilation. I'm just going to go over kind of these three basic ones. There's assist control, which provides the most support. Then there's SIMV, or synchronized intermittent mandatory ventilation, which provides kind of intermediate support. And then there's pressure support ventilation, which provides the least amount of support. Next slide. So this slide just kind of defines what those mean. So assist control, in that mode, the ventilator provides, mandatory breaths in order to meet a set respiratory rate. So if I set the respiratory rate at 12, the ventilator will provide all 12 of those breaths. But of course, patients can trigger their own breaths on top of what the ventilator gives them. And when a patient triggers a breath on assist control, the ventilator will provide full support to meet the requirements that we've set. So if we've set the tidal volume to be 400, the patient breathes on their own on top of assist control, they will get that tidal volume of 400. Then there's SIMV, which I said is intermediate support. So in this ventilator mode, patients will also still get the mandatory breaths that are set. They will meet those requirements that are set as well. But in this mode, if a patient triggers their own breath, the ventilator just provides kind of partial support. We'll set something called a pressure support for those patients, but they may not meet, the full requirement we've set. So for example, if these patients may be a little bit weaker, they breathe on their own on SIMV, maybe they only generate a tidal volume of 300 and not the full 400. And then the last mode is pressure support. So in this mode, the ventilator is not providing any mandatory breaths. The patient has to trigger all their own breaths. And we set as pressure support for those patients to kind of help them generate a tidal volume. This is the mode that we'll do usually our spontaneous breathing trials on as well. Next slide. Now, how do we actually control ventilation in like assist control or SIMV? So these are two types of modes. You might honestly see more in your hospital. There are adaptive modes nowadays. I'm not going to kind of go through those. I think understanding these will help build a foundation for learning the other ones. But so there's volume control. This is where you set a tidal volume. So that's going to be your independent variable. And then the machine will deliver a certain amount of flow and pressure to receive, to achieve that tidal volume. So your dependent variable will be the pressure, and that will depend kind of on the compliance and the lung mechanics. And so for these patients, you may report that they're on ACVC, their respiratory rate is 12, tidal volume 450, PEEP of 5, and FO2 40%. Then there's also pressure control. So this one is where you set a specific pressure. So that's your independent variable, is your inspiratory pressure. It's kind of like BiPAP a little bit, where you have that inspiratory pressure and expiratory pressure, and that driving pressure is determining kind of your tidal volume that you're generating. So that's your dependent variable. And so you may report that the patient's on ACPC, they're getting a rate of 12, their inspiratory pressure is 25, PEEP of 5, and their FO2 is 40%. And next slide. So, what are kind of initial ventilator settings, or what are appropriate ventilator settings for patients? So in general, the tidal volume, we like to keep this between 4 to 8 cc's per kg of ideal body weight. It's important to note this is ideal body weight and not actual body weight. There is a calculator, MD Calc, where you can just input a patient's height and sex, and that kind of generates a range for you. Generally, if their lungs are okay, I usually aim for 6 to 8 cc's per kg. If they're like more hypoxemic, they have ARDS, I usually aim for 4 to 6 cc's per kg. Respiratory rate, there's not really an exact science. Generally above 12 per minute. I would say if the patient's acidotic, they had a high respiratory rate before intubation, you may consider a higher rate for them. Most patients will start with an FO to 100% right after they get intubated, but it's important to kind of wean this down because patients don't need to be hyperoxygenated. So you can generally wean that down every 15 or 30 minutes or so. PEEP usually starts at 5 to 8, but you may consider higher if the patient is still hypoxemic. And then generally after you intubate a patient or after you make any vent changes, you want to check an ABG or a VBG just to make sure the ventilation is appropriate and you're not doing anything to harm the patient. Next slide. So this is just an example of what that MD calculator looks like. So you put the height in, the gender, and then it gives you a range specifically here between 6 to 8 cc's per kg. So how do we adjust ventilator settings? This can be kind of complex, but I will say that, if we want to adjust the pH, obviously that is affected by any sort of metabolic abnormalities that's going on, but you can also try to change the pH based on their ventilation. So PCO2 is indirectly related to our ventilation. So let's say, you have a patient whose pH is less than 7.3, their PCO2 is 40, you kind of want to fix that a little bit. You can always increase their ventilation and decrease their PCO2 by increasing the respiratory rate, increasing the tidal volume, or increasing maybe their inspiratory pressure if they're on pressure control mode. If they're hypoxemic, so if their PaO2 is low on their ABG, you can change their oxygenation by increasing FiO2 or increasing the PEEP. Next slide. And then I want to just briefly talk about, other forms of airway you may see in the ICU. So most of the times you'll see patients who are endotracheally intubated, mostly orally, sometimes nasally. You may also see patients with tracheostomies. This is when either a surgical or percutaneous tract is made through the neck, into the trach. And these patients, you can see they still have their trachea is still patent with their oral and nasopharynx. So in these patients, if their trach falls out, there's some sort of medical need for a new emergent airway, you can always intubate these patients from above. You may also see patients with laryngectomies. And these patients will have a stoma that's present. Their larynx is actually surgically removed. And because of that, their oral and nasal passages are not patent with the trachea. So in these patients who have a laryngectomy and they, let's say, need an emergent airway, you cannot intubate these patients from above. You cannot bag these patients from above. You will have to either put a tube in through the stoma that's present. It can be an ET tube or a cuff trach, or you can bag these patients through their stoma as well. Generally, these patients should have like a little sign on their door that says if they have a trach or a laryngectomy and who to call if there was an emergency as well. Next slide. Now I'll kind of move on to kind of common respiratory diseases you may see in the ICU. So something really common you'll see is probably community-acquired pneumonia. If they're in the ICU, they probably have severe community-acquired pneumonia. This is what the IDSA defines as severe. So one major criteria, so septic shock or, respiratory failure requiring mechanical ventilation, or 3 minor criteria on the left. Next slide. So in general, community-acquired pneumonia is a clinical diagnosis that's supported with an infiltrate that's seen on chest X-ray or CT. On this chest X-ray, you can see that there's a right middle lobe infiltrate here. The diagnostic evaluation for severe CAP includes sputum cultures, blood cultures, a urine strep, and Legionella. I get a respiratory viral panel in all these patients, and if I'm going to treat them for MRSA, I'll always get like an MRSA NIRS. It's important to note that 60% of patients with CAP have negative culture data as well. Next slide. So in general, the empiric treatment for severe CAP includes an IV beta-lactam, so Unison, ceftriaxone, cefepime, etc., plus a macrolide that covers for atypicals. If patients have allergies to these meds or can't tolerate them, you can also consider a respiratory fluoroquinolone like levo or moxifloxacin. You don't need to cover for MRSA and Pseudomonas for CAP unless there's any risk factors that suggest you need to. So the risk factors that kind of the IDSA recommends is, if patients have ever isolated MRSA or Pseudomonas in their sputum before, or if they've been recently hospitalized within the last 3 months and received IV antibiotics. There may also be a role of steroids in severe CAP. There are in certain times where you would definitely avoid it. So if patients have influenza, if you're concerned for fungal infections, but there have been trials that have suggested, for instance, the Cape Cod trial in 2023, that have suggested a lower mortality if we give hydrocortisone 200 mg daily in patients with severe CAP. So just something to kind of consider. And generally, you just treat these patients for 5 to 7 days. Next slide. You may also run into, especially in the ICU, hospital-acquired and ventilator-associated pneumonia. Both of those occur either 48 hours after hospital admission or 48 hours after being on mechanical ventilation. For these patients, I empirically will usually cover for Pseudomonas and MRSA. I'll do kind of a good workup, sputum cultures, blood cultures, and then kind of narrow based on the culture data that I receive. These are kind of the common antibiotics I use to cover for Pseudomonas and MRSA. And then duration is usually for 7 days as well. Next slide. You may also run into asthma, and then the next slide I'll talk about COPD exacerbations in the ICU. The causes for asthma, are usually like viral infections, allergens, pollutions, not adherence to therapy. It's important to note that patients with asthma are not like COPD patients. They are not chronic retainers. So if you actually check a gas on a patient with asthma after they've been treated with some bronchodilators, gotten some steroids, and their PCO2 is normal, it's actually a kind of a bad sign that they still have severe airway obstruction. You would actually expect their PCO2 to be a little bit lower because they tend to be more tachypnic. The backbone of therapy for asthma are bronchodilators, albuterol plus or minus ipratropium. You can give albuterol a ton up front, so I wouldn't be shy about that, and then kind of space it out every 4 to 6 hours. You give steroids for asthma. I've seen patients get tons of steroids up front, like IV methylpred 125 in the ER, and you can schedule it Q6 to Q12. And then you can kind of taper it to PO steroids when they're doing a little bit better. In general, for asthma, we don't really give antibiotics unless there's kind of strong evidence of infection. In the ER or kind of immediately, you can give them magnesium as well. And then in general, non-invasive ventilation like BiPAP is not really strongly recommended, but it can be used to support patients with asthma exacerbations. Next slide. COPD exacerbations are defined by a change of baseline of like cough, shortness of breath, or sputum production. They have kind of similar kind of triggering causes, viral bacterial infections, GERD, aspiration, PE, and heart failure can also trigger COPD exacerbations. The treatment backbone is kind of similar to asthma. We give bronchodilators. We also give steroids as well. I would say that mainly the big differences are in general for COPD exacerbations. If they're admitted to the hospital, we will cover for CAPS. We'll give them some antibiotics. And then BiPAP is actually recommended in these patients with respiratory failure. Next slide. So now I'll talk a little bit about ARDS, which is something you may run into in the ICU, especially in the medical ICU. So the pathophys of ARDS is essentially there's some sort of lung injury that causes a ton of inflammation, and that causes your vessels to become leaky in the lungs, and it causes non-cardiogenic pulmonary edema. That decreases the compliance of your lung. You lose a lot of healthy lung tissue, and that's what ultimately causes your respiratory failure. So there's the Berlin criteria, which is needed to diagnose ARDS. It's 4 things. The first one is that it's acute onset, so within 7 days of a known trigger. There's diffuse bilateral pulmonary infiltrates on imaging. It is not exclusively due to heart failure or volume overload, and then the PF ratio is less than 300 despite a PEEP of 5. Sorry, just click next. Yeah. So the causes of ARDS is not simply just like a pulmonary cause, although pneumonia and aspiration do lead to ARDS. Toxic inhalations, pancreatitis, sepsis, drug overdose. So a lot of systemic things can also lead to ARDS as well. Next slide. So what is the PF ratio? We talk about this a lot, especially in patients who are managing for ARDS, and it's essentially the PaO2, which is what is measured on an ABG, over the FiO2, so the percentage of oxygen we're providing for a patient. So if, let's say, their PaO2 is 65 on an ABG and they're receiving an FiO2 of 60%, their PF ratio is 65 over 0.6, and that's a 108. So that's consistent with moderate ARDS. And then you can just click next 2 more times. We have mild PF ratio, mild ARDS, which is 200 to 300, moderate, which is a PF ratio above 100 and less than 200, and severe ARDS, anything 100 or less. Next slide. I'm not going to go over in detail too much about the principles of management of ARDS. I just kind of wanted to familiarize you guys with what you may see in the ICU. I think the big thing we kind of focus on in ARDS is protective ventilation. So low tidal volume ventilation. So these patients will get very low tidal volumes, 4 to 6 cc's per kg, and it's been shown to reduce mortality. You will also see these other things like maybe higher PEEPs. You may prone these patients, like flip them on their belly. You may give them steroids or paralytics. You may give them prostacyclins or like pulmonary vasodilators. You may diurese these patients just to make their lungs a little bit on the drier side. And they may have permissive hypercapnia. So anything, honestly, with a pH greater than 7.2 is usually fine in these patients. Next slide. You may also see PE when you're in the ICU. Generally, these patients are diagnosed with the CTPE, sometimes with a VQ scan if we're nervous about giving contrast. There are different ways of risk stratifying PE. I mean, the AHA just released like 2026 guidelines where they group patients from A through E. I'm not going to go through all of that, but I think the main things you have to assess in these patients is their hemodynamics, right? Are they hypotensive? Were they transiently hypotensive? Are they tachycardic? What are their cardio biomarkers? What is their trope or their BNP? And what does their RV look like? Based on the CT scan, sometimes they'll comment on the size of the RV or a bedside ultrasound or a formal echo. The anticoagulation of choice in PE is actually low molecular weight heparin, so Lovenox. But of course, if there's contraindications to that, we can do IV heparin. And in general, most hospitals now have like a PERT team, which is kind of an interdisciplinary team of pulmonology, cardiology, IR, surgery, etc. And they kind of come and discuss patients who are maybe more intermediate or high risk to decide if they need more invasive interventions or systemic fibrinolysis. So getting them involved early, I think, is really appropriate for these patients. And then patients with PE may also develop obstructive shock, RV failure. So in those patients, you may consider adding inotropes and pulmonary vasodilators. Next slide. So I wanted to show this chest x-ray here. I'll just kind of go over briefly just because we're running low on time, but you can see there's no lung markings here at all on this left side. So, we're concerned that maybe this patient has a pneumo. And then we can see that the trach is deviated a little bit to the right. The mediastinum is being pushed to the right as well. So in the right clinical context, if the patient is hypotensive, tachycardic, they have descending neck veins, we may consider that this patient might have a tension pneumo, which is a respiratory emergency. Click next. One more time. So the management for a pneumothorax, especially in patients who are unstable or severely symptomatic, is to place a chest tube. So these patients will initially be placed on a chest tube to suction. And that suction will generally be anything between -20 to -40 centimeters of water. You can see here on this right side, this is an image of what an atrium for a chest tube might look like. Inside the purple box is where I'm showing kind of the suction part of that. So if the patient is attached to suction, that orange, this orange part, the suction bellows, this should be inflated up to kind of where the arrows are. And this is kind of the suction that we've adjusted for the patient. Once the pneumothorax is resolved, you may hear that we place the chest tube to water seal, which just means we're placing it to gravity and we're no longer placing it to suction. And then we may clamp the chest tube, meaning the chest tube is kind of closed off to the patient and we're kind of simulating what would happen if we remove the chest tube. So I think that's the end of my slides for the respiratory section. I believe we're gonna take like a short intermission for 5 minutes before we move on to cardiovascular in the ICU.
Yep. Thanks, Dr. Wu. Yeah, Dr. Wang will pick up with cardiovascular just after a 5-minute break.
I think I just tried to request remote control. Okay, let's see if this works. Yes, I think I did it. All right, I guess I'll get started in about another minute if that's okay with people. Okay. Also, feel free to ask questions in the chat, and depending on time, we'll try to answer it. Otherwise, we can try to answer some of these afterwards. Okay. All right. So I'll be presenting on the cardiovascular system in the intensive care unit. Just general overview. We're gonna have to, unfortunately, a bit of a pharmacology lesson. I'll try to go over both the generic name and some of the brand names and abbreviations you'll hear, because I think you'll find out pretty quickly we seem to really like our abbreviations in the ICU. Go over shock, different types of shock, things to think about, along with some cardiovascular emergencies. And if we have time, I would love to talk a bit about mechanical circulatory support, or MCS, some of you might see, some of you might not. It completely depends on your institution, which ICUs you're in, and kind of what's your institutional norm. I do not expect you to really remember most of this. This is more of at least you've seen it once, and hopefully whenever you're in the situation and you see it again, it's just going to help jog a bit of a memory and make things a bit easier to understand. So for the vascular system, the way I like to think about it is it's simple at the end of the day. It's two pumps, the right side of the heart, the left side of the heart, and a bunch of pipes, or all your blood vessels. So that's kind of how I'll be tackling this portion. So first things first, when it comes to blood pressure, there's two ways you'll see it measured. So the classic is your blood pressure cuff, which is what most of us are familiar with. For that, MAP, or mean arterial pressure, that's your average blood pressure throughout the cardiac cycle. That's actually measured by the cuff itself. Your systolic diastolic is calculated by whatever proprietary algorithm that particular company uses. Your arterial line is a specialized catheter, or then it's like an IV, but it goes in your artery instead. And with an arterial line, it measures your systolic, diastolic, and MAP. So all the numbers that it pulls up are actually measured. And when it comes to blood pressure in the ICU, we often think of it as more of MAP rather than systolic or diastolic blood pressure. You'll often hear us say MAP over 65. That comes from multiple sources and has been heavily induced by a surviving sepsis campaign. However, asterisk to that, there was a recent 65 trial from 2020 that showed evidence older patients may actually be okay with MAP goals of 60 to 65, but I would defer to your institution and kind of what their practice is. So your blood pressure is affected by your cardiac output and your SVR, or systemic vascular resistance, otherwise known as how tightly or clamped down your blood vessels are squeezing. And your cardiac output is your heart rate times your stroke volume, so the amount of blood your heart pumps in a minute. Cardiac output is a great number, but you'll often hear us talking about cardiac index instead, which is just cardiac output divided by body surface area. It accounts for body size, since someone who is only 4'6" versus someone who's 6'6" will have very, very different needs on how much blood they actually need every minute. So ways to think about it is your blood pressure is based on your heart rate, your stroke volume, and how tightly your blood vessels are squeezing. Right. So feel free, take a photo. I don't expect people to ever memorize this, especially coming in. So these are going to be your uppers, so your pressors that will increase your blood pressure, your downers, things that will decrease your blood pressure, and squeezers, or things that will increase contractility. So phenylephrine or phenylephrine, depending on location, this is your alpha only. You don't really see it much in most of the ICUs. You'll often see it used as a push dose, or more often in the operating room, especially if you're anesthesia. It does cause some reflex bradycardia, and it is nice to use when you have a patient who's hypotensive, needs something to increase blood pressure, but their heart rates, they're tacking away at like 110s, 120s. They might actually benefit from some of that reflex bradycardia. Brand name for Phenylephrine is neosynephrine, so you might hear people say neo. And the other way you'll hear it called is phenyl or phenyl, so just quick abbreviations. Norepinephrine is the next one. It's alpha and beta agonist. It's probably the most common you'll see in the intensive care unit. Brand name is Levofed, so you'll hear it abbreviated as Levo sometimes. And next one, epinephrine. So beta 1, beta 2, alpha 1. It's great. It's both helps your blood pressure, but also can increase contractility. However, disclaimer, if you're running someone on epinephrine, it can cause increases in lactate. So depending on your dosage, you may need to interpret your lactate with a bit of caution. Vasopressin is the next one. It's a bit funkier. It doesn't work on your alphas and betas. It works on V1 receptors in smooth muscle. It's also known as antidiuretic hormone. It's often a second-line medication. You'll usually start with norepinephrine and then add vaso as needed. So it's great because it actually has very little to no effect on your pulmonary vascular resistance. So if you have a patient that has pulmonary hypertension, this may actually be a better choice in pressor. So the next two are methylene blue, you often won't use unless you're in a bit of dire straits. It works to inhibit nitric oxide. However, there is a risk of serotonin syndrome, and it will actually increase your pulmonary vascular resistance. So keep that in mind if you have a patient with pulmonary hypertension or if they have a very bad right-sided heart. And if your patient has G6PD deficiency, you will end up causing hemolytic anemia instead, so avoid it in those patients. Finally, you may have patients that you see are on midodrine. That's an oral alpha agonist. Think of it as phenylephrine, but in pill form rather than IV. You'll often have patients who are on hemodialysis use it to help bump up their blood pressure during dialysis. So sometimes your patient's blood pressures are too high and you actually have to decrease it. So things you'll often see is clofidipine or nicardipine. These are your calcium channel blockers. They are infusions. Usually you can't run them outside of the intensive care unit, so having to require them is one of the indications for remaining in the intensive care unit. Big thing with clofidipine is it is in a fat emulsion. So if you have a patient with acute pancreatitis, that's not a great choice. Nicardipine is not in a fat emulsion, so good alternative. And something else that can happen when you have patients on either clofidipine or nicardipine is it can cause what's called pulmonary shunting, where you start these medications to decrease their blood pressure, and all of a sudden they become hypoxic without any other changes. So at that point, give them more oxygen. However, you may have to stop these medications and switch to something else. So esmol, labetalol, these are beta blockers. They generally decrease your heart rate more than your MAP. But they will decrease MAP. Nitroglycerin, this is your venous dilator and arterial dilator. It decreases your preload more than your afterload. However, if you have a patient coming in with an inferior MI or they're preload dependent, please use with high amounts of caution. Hydralazine, it's an arterial vasodilator. You can give it as push or oral. And it's soft. So sometimes you'll end up using hydralazine to wean people off the nicardipine or clofidipine to get them out of the ICU. And nitroprusside, you will sometimes see it used. Big word of caution with that is if you're using it for a longer term, you can end up causing cyanide toxicity. So great for short-term use, try to get people off of it. And finally, your inotropes. So epinephrine will help increase your heart squeeze. So will dopamine. Also, you'll hear it called dopa and dobutamine. So all of these will help increase heart contractility. The thing is, when you increase heart contractility, you also do increase the risk of arrhythmia. So if you have patients that are high risk of having arrhythmias, these may not be the best choice. Milrinone, it's a phosphodiesterase inhibitor. It's great if you have someone who has a weak heart, but for whatever reason, they also have hypotension, since it does cause vasodilation. So you can take advantage of it and actually use it to help control someone's hypertension. Last one, this is just for extra credit. You may have an attending mention it or ask about it. Levosimendan, it's also an inotrope. It increases contractility by sensitizing your cardiac myofilaments to calcium. And it actually does not increase O2 consumption. However, unfortunately, in the US, it's not FDA approved, so we can't use it here, but it is used in Europe and South America. All right, so shock. So shock is defined as circulatory failure resulting in inadequate cellular oxygen utilization. And when you have a patient who's in shock, common signs you'll see is hypotension. So systolic blood pressure less than 90, MAPS less than 65. You'll see signs of end organ dysfunction. So decrease in urine output or sometimes complete cessation of urine output. You may have altered mental status. So sometimes when you think, going back to neuro, when you think someone is delirious or altered, something to think about is, are they altered not because of delirium, but because they're actually in shock? Since that can lack of recognition of that can often delay starting treatment for shock. And finally, you will often see an elevation in lactate greater than 2. So elevations in lactate, it's seen as evidence of impaired cellular O2 utilization. However, lactate is also cleared by the liver. So if you have a patient in liver failure, they may just have a delayed lactate clearance. And if they're thiamine deficient, that may also cause a delay in the lactate clearance. Throwing back to basic biochemistry, Krebs cycle, things you thought you might have never see again. So the thing is, thiamine, if you're thiamine deficient, pyruvate can't enter the Krebs cycle. So it forces pyruvate to be converted to lactate, which will also lead to elevated lactate levels and a metabolic acidosis. So if you have any patients that you think are at risk of malnutrition, so chronic alcoholics, just sometimes very frail patients, just give them some thiamine. It might actually treat the lactic acidosis. So in terms of types of shock, there's generally 4 types of shock is how we think of it. So you have your distributive or vasodilatory. That's when the pipes in your body are just leaky. Hypovolemic, this whole system is just empty. Cardiogenic, there's something wrong with the right heart, the left heart, your pumps just are not pumping. And finally, obstructive is something's preventing your pumps from actually pumping. And as much as we like to think of it as 4 distinct categories, people aren't always that simple, unfortunately. So, for instance, patients who are in septic shock, which is a type of distributive shock, about 25% will end up actually developing cardiogenic shock as a result. So, the rule is your patient can have as many types of shock as they want. And now going through the different types of shock. So, vasodilatory, this is going to be your most common type of shock. Your treatment is really, you want to fill the pipes, start some vasoconstrictors to help with keeping the pipes just clamped down, and then also treat the underlying cause. So in terms of underlying cause, there's 2 possibilities. You can have your infectious cause, non-infectious cause. So infectious cause, you'll often hear people saying septic shock or sepsis. So this actually creates a defect in the oxidative phosphorylation in dysfunctional mitochondria. So your tissue, you get the oxygen, but you just can't use it. So that's one of the things you'll find is their O2 levels are often high, despite them sometimes having high lactate and sometimes even being hypoxic. So for septic shock, you want to give fluids, start some pressors, get cultures if you can, blood, urine. If they're intubated or you have good access, get bronchial alveolar lavage or samples from the lungs. However, do not delay starting empiric antibiotics. And if needed, try to obtain source control. So in terms of your antibiotic choice, what you're going to want is you're going to want an enhanced gram-positive coverage. So that's where your vancomycin comes in. And then a broad spectrum agent, which is where the piperacillin and tazobactam, the brand name is Zosyn. So you'll hear people say vancomycin a lot. That's where you'll want to start pip/tazo or meropenem, depending on your institution's bacterial susceptibility. And if there's suspicion for either a toxic shock syndrome, necrotizing fasciitis, or you'll hear necrotizing soft tissue infection, start them on some clindamycin that helps inhibit the toxin production. So in terms of non-infectious causes of distributive shock, you have anaphylaxis. So to treat that, you want to remove the offending agent. So a classic one you may hear of is someone who has had a lot of health exposure to the healthcare environment, children, or really adults with a history of spina bifida, you place a Foley catheter in them, and then they suddenly have severe, profound hypotension, sometimes getting short of breath, itching. Big thing is take the Foley catheter out. They likely have a latex allergy, and the Foley catheter might have contained latex. You want to give fluids to help support their blood pressure. Draw tryptase. So tryptase, you want to draw in ideally 1 to 2 hours after symptom onset, since that's about when levels peak, and then you'll want to draw repeat tryptase later because if the tryptase rises, that actually confirms that this was an anaphylactic reaction. And then in terms of medication treatment, you're going to want one drug to halt the reaction, so that's your epinephrine, and then drugs to alleviate symptoms, so your antihistamines, your bronchodilators if they're wheezing. And then liver failure, this will be addressed in the IM session later this afternoon. So neurogenic shock is another type of vasodilatory shock. You'll see this in patients with spinal cord injuries that are T6 or higher. What happens is they lose all the sympathetics, so their body can't constrict their own blood vessels without additional medications. So treatment for that, you want to give them some fluids, start them on some norepinephrine until their body adjusts. And finally, adrenal insufficiency can cause this, which one of my colleagues will cover later in the endocrine portion. So next type, hypovolemic. To treat hypovolemic shock, you can start vasopressors, but really what you're doing with that is you're just buying time, because if everything's empty, you can't really increase your blood pressure until you fill your tanks. So you'll want to fill with whatever is missing. So you could have hemorrhagic causes where you're bleeding either out or in. So bleeding out, you'll see it in trauma patients, GI bleeds, postpartum patients where they're just having large volume blood loss. Internal bleeding can also lead to hypovolemic shock. You'll see that where they get hemothorax, so blood in the thorax. The retroperitoneal space is also a common place people can bleed into that you just won't see. You won't actually see it from the outside. And big thing to keep in mind is when you get your labs, if they're having large volume acute blood loss, your hemoglobin is unlikely to reflect the acute blood loss. So your hemoglobin might still say 13, but looking at them, they're pale, their lips are pretty much colorless, and they're having blood loss from somewhere. Their actual hemoglobin is probably much lower than what the lab shows. So at that point, if you think it's blood loss, start transfusing. While you're waiting for blood to show up, start some crystalloids, so your lactated ringers, your plasmolite, and normal saline. And then in causes of non-hemorrhagic hypovolemic shock, you also want to give fluids, but a bit more carefully. So if you have a patient with a lot of GI symptoms, they're vomiting a lot of diarrhea, you'll want to replace that fluid. And then in terms of renal, we sometimes are the cause of our own problems. So if we're trying to diurese somebody because they're in heart failure, sometimes we over-diurese them, dry them out a bit too much. Or if they're on continuous renal replacement therapy or dialysis, we sometimes just pull off too much fluid. For those patients, you want to just be very cautious, give a little bit of fluid at a time, because you're trying to pull fluid off them and you don't want to completely undo all your work, but you might need to just give a bit of fluid back in the meanwhile. And finally, for patients, especially if they're surgical, if they have an open abdomen, that's a pretty high area where they'll have evaporative loss. And if they have burns, that's also a very common place to be having what we call insensible fluid losses. So fluid losses that we can't actually measure. And finally, if any of our patients have drains, whether it's a chest tube or drains to different areas, keep track of how much, as part of your daily assessment, take a look at their ins and outs, how much that fluid they're losing from those drains, because that can actually be a large source of fluid loss. So cardiogenic shock, your heart's not functioning for whatever reason. So big thing is, if you can, you want to treat the underlying cause, and in the meanwhile, support the heart. Your treatment, you're going to start some norepinephrine and then add inotropes if you need, and then give time, a lot of time, to see how the heart actually recovers. With your patients in cardiogenic shock, you want to be super, super cautious with fluids because their heart's not pumping super well, whether it's the right side or the left side. So if the left side's not working well, but the right side is, you give a lot of fluid, the right side is doing great. It's going to keep pushing fluid forward, but the left side can't match. So you're going to end up actually giving your patient pulmonary edema with too much fluid. And if the right side doesn't work and you give too much fluid, you can end up causing a lot of fluid to back up and causing intestinal edema and causing a lot of your own problems that way. For patients that you suspect cardiogenic shock in, your POCUS or point of care ultrasound, along with your transthoracic echoes and your transesophageal echoes, those will be huge helps because these patients are super, super dynamic in how they respond and how their heart function is doing. So you'll want to assess them throughout the day. If you've never done these before, being in the ICU, it's a great time. Ask your fellow, ask the senior resident to kind of show you a few quick things. And at the end of the day, if you can just get 1 or 2 views of the heart, that will actually let you do quite a bit of assessment. And finally, if they're really not getting better, but rather getting worse, you should, at that point, consider mechanical circulatory support or MCS. So this will be institutional dependent what's offered and what could be done and whether or not your patient qualifies. So common causes of cardiogenic shock. So your myocardial infarctions, your heart attacks, this is about 2/3 of the causes. Best thing you can do for it is revascularize, whether it's through a PCI or a stent placement or through a CABG or open heart surgery with coronary bypass. Second, if your patient has an arrhythmia, that will cause their heart just to not quite function the way it should. And if you have a patient that has arrhythmias, big thing is you want to check their electrolytes. So rule of thumb in the ICU, the way I like to remember is 2, 3, 4. So ideally you want everyone's magnesium above 2, phosphate above 3, potassium above 4. And then with arrhythmias, you want to try to correct the underlying rhythm. For these patients, the dopamine and epinephrine I mentioned earlier, they're probably not going to be great choices in inotropes just because they can be proarrhythmogenic. And some of you may, if you're in the CT ICU, you may have what's called post-cardiotomy shock, or rather, this just refers to cardiogenic shock as a result of cardiac surgery. Oftentimes, the heart muscles will be either hibernating or a bit stunned from surgery. So big thing for this is you just give inotropes, support the heart, and wait. And then peripartum cardiomyopathy. So if you have a patient who is either currently pregnant or recently delivered and they're in shock, that's something to keep in mind in your differential. That it might not be infection actually, that it might actually be their heart not working. So this will cause systolic dysfunction. So their heart just won't be pumping as well as it should. So these patients, drop an echo probe on them, like take a look at the ultrasound, and you might actually see it's their heart rather than anything else not working. So other thing for hearts, one thing I like to bring up is LV outflow obstruction or left ventricle outflow obstruction. The reason I bring this up is treatment for this is a bit different than everything else for cardiogenic shock. For these patients, you actually want to give fluids rather than avoid fluids, and you want to decrease their heart rate. Because what's happening here is actually these are patients with very, very thick LVs to the point where if their LV is too empty, when the LV squeezes, the mitral valve actually gets suctioned into the septum and essentially blocks the exit for the blood. So the heart's essentially preventing itself from ejecting. All right, obstructive shock. So something's stopping the heart from actually moving blood forward or getting blood to return back. So things that will stop the heart from filling or decrease your preload, your tension pneumothorax, your cardiac tamponade, and if you have patients that are ventilated, if you have excessive PEEP or positive end expiratory pressure, that can actually decrease the amount of blood returning to the heart. And then if you have patients with abdominal compartment syndrome, so essentially there's too high of pressure in the abdomen that it actually causes compression of your IVC and blood just doesn't flow back. So for those, the things you need to do is really try to relieve whatever's causing the obstruction. So if it's due to excessive PEEP, if you can, try to drop the PEEP down on the ventilator and abdominal compartment syndrome. Once that's diagnosed, that's considered pretty much a surgical emergency at that point because treatment for that is relieving the tension in the abdomen. If your patient's stable, that's when you try to get them down to the operating room, surgeon opens abdomen. However, if they're truly unstable and it's not safe to leave the intensive care unit, you may end up finding out a lot of your intensive care units are actually constructed in a way that they can be used as essentially ORs in emergency, where you may end up doing a bedside XLAP on your patient. So other things that will cause obstruction is you can decrease your cardiac output. So pulmonary embolism, where you have a blood clot that goes from your systemic through the right heart and then into this area that blocks blood flow to the lungs. So that will decrease the amount of blood your heart can pump out. And then if you have mediastinal tumors, so things that are compressing right here, that will prevent the heart from effectively pumping. And finally, things that will increase afterload or make it harder for your heart to pump is if you have severe aortic stenosis, that will also make it hard for your heart to work. So feel free, this is just here if you want to grab a screenshot or a snapshot, just things to see. CVP is your central venous pressure. So that's the pressure, that's the final pressure of all the blood returning back to your system through your IVC and your SVC. All right, cardiovascular emergencies. So big thing, first one, cardiac tamponade. So fluid essentially builds up around the heart. This is where your echo will help a lot. So you see this black area right here around the heart, that should not be there. What happens is fluid builds up around the heart, leading to compression. So all the chambers in your heart, the pressure is actually equalized. So blood can't really move forward, can't really move in or out. It, depending on severity, it is an emergency and will require drainage. If it's been gradually happening, patients can tolerate a shockingly large amount of volume. I've had patients where after we diagnose it and drain it, some of them have had 800 milliliters in. One of my patients had 1.8 liters of blood in there. And if it's acutely happening, even small volumes such as 50 mLs can cause cardiac tamponade. You'll see them hypotensive. You might see their jugular vein distended, and you'll sometimes see arrhythmias. With this, you just have to have a high degree of suspicion. So anytime you have a patient who they're just hypotensive, some reason they look fluid overloaded despite having a low blood pressure, pop the ultrasound on and take a look and see if there's extra fluid around the heart. In terms of arrhythmias, general rule of thumb is if you can, get an EKG. You're going to do some stuff. So check their electrolytes, give medications if they're stable enough, or just cardiovert them. And then you should mostly be successful. If they're unstable, the answer will be electricity. However, if they're awake and you're going to cardiovert them, as long as they're not actively crashing, you might want to be a bit nice and give some sedation first before you cardiovert them, because this is not a pleasant experience, to say the least, for your patients. But if they're truly unstable, you know what? Just shock them. So before I continue the IM Bootcamp, they'll actually go over a bit more of the different rhythms along with diagnosing them in their session. So I'll be skipping that to avoid too much repetition and for some time. So bradycardia, this is when your heart rate less than 60 or less than 50, depending on your sources. For this, you want to get an EKG, but generally if they're asymptomatic, you just kind of let them be. If they're maintaining blood pressure, no changes in the mental status, and all their organs are perfused, great. However, if they have a sustained heart rate, my rule of thumb is usually less than 40. I like to give some glycopyrrolate just to bump the heart rate up a bit, because if they have a sustained bradycardia, they're actually at increased risk of reentrant arrhythmias and further deteriorating. The reason you want the EKG is, apparently my little electricity signs didn't show up, is you want to look for heart blocks, because if they have a Mobitz type 2 heart block like this, where they're dropping beats, you want to start pacing them, because there is a risk of progression to complete heart block, and that can happen without much warning. If they're in complete heart block, at that point, you want to start pacing them transcutaneously, which is from the outside. Not super pleasant, but that's going to be the fastest. You just slap pads on and start pacing them to the point where their blood pressure is stable. And then once you have a bit of time and a bit of stability, you can then place a transvenous pacer at bedside until electrophysiology comes by and they're able to place a temp perm or a permanent pacemaker. So atrial fibrillation with rapid ventricular response, you'll hear it called AFib RVR. So you get your irregular heart rhythm, usually above 100 beats per minute. If they're hemodynamically stable, treatment of choice is then medical rate control. So outside of the ICU, you'll often see people on diltiazem or beta blockers, so your metoprolol. These are great. However, they do cause hypotension in your patients, and these are both negative inotropes, so they will decrease the amount of squeeze. In the ICU, there's a good chance your patient's on some kind of vasopressor or something to help increase their blood pressure. So your most likely drug of choice will actually be amiodarone, which at that point, the risk with amiodarone is you can cause a conversion to sinus rhythm. And depending on how long they've been in AFib for, sudden conversion to sinus rhythm does carry a risk of stroke. So if they've been in AFib for less than 48 hours, you're fine. If they've been in AFib for longer than 48 hours, there's increased risk that they do have a clot in the left atrial appendage. And if sudden conversion to sinus will have a high risk of stroke. So that is the word of warning. And then if they're unstable, your answer is shock. So synchronized cardioversion. However, when you cardiovert them, there is a risk of stroke if they've been in AFib for more than 48 hours. So if you're planning to cardiovert them and they've been in AFib for greater than 48 hours without being on anticoagulation, ideally you would want a transesophageal echo to evaluate for clot before you do so. And just pro tip, if you start someone on amiodarone and your team says, oh, let's do a 5-gram amiodarone load. Usually when they refer to the 5-gram load, that actually refers to oral dosing, not IV. Excuse me. So the conversion from IV to oral is a 1 to 2. So 1 gram of IV amiodarone is 2 grams of oral amiodarone. So if they say 5-gram load and you're doing it all as IV, that you'll end up doing a 2.5 gram IV load instead. So SVTs, you get your narrow QRS tachycardia, your heart rate's greater than 100. Oftentimes when I see these, heart rates are often 140s, 160s. So if they're stable, their blood pressure's not super low in the ground, you can try vagal maneuvers. So a carotid sinus massage where you just kind of massage right here like that. You can try it. However, do not do it if your patient has known carotid stenosis or you've heard bruise there, because if there's any narrowing of the carotid and you massage it, you can risk dislodgement of a plaque and cause a stroke that way, or a Valsalva maneuver. So that's where you tell them to bear down like they're trying to have a bowel movement. That can sometimes convert them. If not, you can then try to give adenosine. So adenosine, it's super, super short half-life. So when you give it, you're going to essentially want to have 2 stopcocks, one with the adenosine, one with a flush. It's just going to be a 1-2 push because you just want to get it to the heart as fast as you can. You'll start with 6. If that doesn't work, 12. If that doesn't work, another 12. If that doesn't work, just electricity is the next answer. If you do give adenosine, it's nice to give a patient a heads up that they're going to feel a sense of doom. They're going to feel like they're dying, because what you're actually doing is you're just causing the heart to stop and trying to reset it. If it's unstable or doesn't terminate, that's when you just cardiovert them again. However, if you have a patient with known underlying Wolff-Parkinson-White syndrome, so that's where you see right here that delta wave in front of the QRS. Big things is no AV nodal blockers, so no amiodarone. This is probably the one patient that amiodarone will be the wrong answer for. What you'll want instead is procainamide, or honestly, cardiovert them. And then ventricular tachycardia. These are the ones that you should be pretty scared about. And if anyone calls you about VT, if your senior, your fellow, your attending's not around, call them ASAP, go run see the patient. So this might be a bit of a, ironic statement. If they're in stable VT, as in they have this rhythm through all their leads, but their blood pressure's not through the ground, they're somewhat okay, you can start with an amiodarone bolus. However, if they're unstable at that point, just cardiovert them. And then torsades, that's a special mention. So that's where you get this VT. However, you get that winding ribbon. For that, you can cardiovert them, but you also want to give them usually 2 grams IV magnesium will help. And along with torsades, something that you may see, especially in your patients with cardiogenic shock or post-MI, is what's called RLT phenomenon. So you can see down here, they have PQRS and then their T waves right there, and then another PQRS-T. So what happens is right here, you PQRS, and then right where the T wave should be, you actually have essentially another, usually a PVC of some sort, but you have the R wave superseded on the T wave, and that actually can initiate torsades or VT in a patient. So if you see a patient where their own heart is actually doing that, one of the ways to kind of fix it in a way is you can do what's called overdrive pacing, where you put either a transvenous pacemaker or even just transcutaneous for the time being, and just increase the rate over their native heart rate. And that can sometimes keep them out of it so that you don't have to continuously shock them. And if overdrive pacing works, that's when your next answer is consult EP, get them to either put a temporary pacemaker in or a permanent pacemaker. Finally, ventricular fibrillation. If you see this on a patient, take a deep breath. Your answer is going to be ACLS, time for a code. It's going to be a shock with epi, shock with amiodarone, maybe lido, and try to treat your underlying causes. And if they're still shock resistant while getting CPR, if your hospital has it, consider calling for ECMO at that time. So finally, the heart can't have all the fun. One of the biggest vascular emergencies you'll find in the ICU is you'll have a patient come in with an aortic dissection. So that's when the part of the inner layer of the aorta separates, and you then have two channels, a true lumen and a false lumen. You have your type A and your type B. Your type A means any dissection that goes from the heart up to the left subclavian. So that is an OR emergency, call CT surgery. The most you're going to do for them in the ICU is maybe place bilateral radial arterial lines before they get rushed to the operating room. Oftentimes they'll come from an outside hospital or get diagnosed in the ED. Type A, they'll sometimes just go straight to the operating room. So, and the reason for that is if the major vessels are being fed off the false lumen, they're going to be hypoperfusing the brain, the head, the upper extremities, and it can dissect into the heart to the point where it will affect your aortic valves and your heart itself. Your type B, these are urgent, less so emergent. So these will often eventually require surgical repair. They'll come to you for what's called impulse therapy. So they're here for heart rate control, blood pressure control. So that's where your esmolol, your nicardipine, that's where you'll really be using them. And for these patients, you'll want to monitor their lower extremity pulses because it can dissect further down. And if it ends up affecting lower extremities, they may need surgical repair sooner than later. And finally, if they have an aortic aneurysm, that's when the aorta kind of balloons out. There's a huge risk of rupturing. If it ruptures, that's honestly a huge emergency, massive blood, etc. But for these patients, if you have them or if they have a known aortic aneurysm, avoid all fluoroquinolones because that can increase risk of rupture. And you want to manage their heart rate, your blood pressure. Usually you want heart rate less 60s to 80s, blood pressure less than 120, 130. They will eventually need surgical repair, but usually not an emergency run to the operating room kind of situation. So for the sake of time, I will skip this. Feel free to snap a photo. So this is what I mean by mechanical circulatory support. You have your temporary ones and your long-term ones. And in terms of if your hospital does offer ECMO, you'll hear venous arterial ECMO, which think of it as a heart-lung machine, and veno-venous ECMO or VV ECMO, that is just a lung machine. If you have a patient on VA ECMO, something my program director always likes to say is never ever suggest a sweep trial with zero, because with VA ECMO, you're replacing both heart and lungs. And if you do a sweep trial of zero, you're actually saying don't give any oxygen through the heart-lung machine, and you're essentially creating a shunt. So if they ever ask for a suggestion and they're saying they're going to do a weaning trial or something like that, if they're on VA ECMO, the answer is never sweep off or sweep zero. All right. Okay. So these are extra slides that I will skip for now. Next portion.
Thank you for that, Dr. Wang. For GI and ICU, just a couple quick topics. Next slide, please. So nutrition is a big thing. A lot of our ICU patients are very high risk for malnutrition. So we have to feed these people one way or another. And so what I want you guys to take away from this is, it's very important to feed patients, both for one, malnutrition, and two, to protect the sort of gut integrity so you don't have bacterial translocation. So how can you feed people? Well, they can eat themselves. But a lot of times in the ICU, they may have issues like dysphagia or they're an aspiration risk. So then, we have to ask ourselves, okay, how can we feed them? Usually that'll be through something like an NG tube. And so, next slide, please. So this is something that will probably come up pretty often for you guys. So how to determine NG2 correct placement. So you want to make sure you get a chest X-ray that goes straight down the midline, passes under diaphragm, and then goes to the left. And you want it about 5 to 10 centimeters past the gastroesophageal junction. Now, where this can go wrong is it can go down one of the lungs, or it can get coiled up in the esophagus, or it could just be coiled up in the mouth. So always important to confirm where your NG tube is. Now, if a patient can't tolerate NG tube feeding, maybe they have gastroparesis and things are just not moving forward. Sometimes what we'll do is we'll place something called a post-pyloric tube, so a nasal duodenal tube. Now, how do you make sure that this patient has the ND tube past the stomach and into the duodenum? Well, it's going to cross. So it's going to go left first, then it's going to cross the midline to the right side, and then it's going to go down. So that's how you confirm, again, with a chest X-ray. Next slide, please. If for whatever reason we can't feed their gut, then the alternative option is to give them nutrition through the IV. And this is what we call parenteral nutrition. And you have peripheral, and then you have central. So peripheral is usually a much more dilute concentration, so you're giving these patients a lot of volume. Central is a little more concentrated. The issue with this is you can have line infections. They need a central line. For central, you can get volume overloaded. Because you're not feeding the gut, you can cause intestinal atrophy and have bacterial translocation. You can also have cholestasis and acalculous cholecystitis. So it's important to try to feed the gut when you can, but if you can't, you can always rely on this. Next slide, please. So when does a patient have to be NPO? So NPO being nothing by mouth. Well, one, if they're at aspiration risk, but you can always, for these patients, you can always place an NG or ND tube pre-procedural. So if they're going for an operation soon, we usually make them NPO by midnight. And it really, it depends on your institutional guidelines because we have to make sure that their stomach is empty before the induction of anesthesia because they're in aspiration risk. And then lastly, if they have some sort of GI pathology that's a contraindication of feeding, like a mechanical obstruction, ileus perforation, or mesenteric ischemia. Next slide, please. So this is just a little flow diagram you can use to determine, how can I feed my patient? Next slide, please. Another thing you'll come across a lot is GI prophylaxis. So what is GI prophylaxis? Well, a lot of patients in the ICU are susceptible to having stress ulcers just from being critically ill. And so normally, we give patients just a PPI, so either pantoprazole. Some places will still use H2 blocker. But an important thing is if you're already feeding somebody through the gut, that's already protective in itself. So one, always feed people when you can. If you can't, consider PPI. Usually these are just for your more critically ill patients. Next slide, please. And then one last thing I want to go over in terms of GI is acute mesenteric ischemia. This is something that may come up. It's very common in ICU and it's often underdiagnosed. This happens when you have ischemia to the gut, either from arterial embolism or thrombosis, or just patient being on high pressures causing vasospasm. And it usually presents as a patient who comes into the ICU for one reason or another, maybe pneumonia, and they're just not getting better. The lactate's going up, their septic shock is getting worse, even though we have them on the appropriate antibiotics. Someone says, oh, their belly feels a little more distended, and you get a CT scan and you see pneumatosis or dead bowel on the CT abdomen. And this requires an urgent surgical consult, usually for an X lab to take out necrosed bowel, and also starting both gram-negative and anaerobic coverage. Next slide, please. Okay. In terms of GU and ICU, we'll just talk about a couple quick topics that I think are really important. Next slide. First one is going to be hyponatremia. So you're bound to get a patient who comes into ICU just because their sodium's low. Now, how do you go about correcting it appropriately? Well, a couple things. Next slide, please. The thing we're always worried about is osmotic demyelination syndrome. This is a severe irreversible neurological disorder. And if it's really severe, you can get locked-in syndrome. This is every nephrologist's worst nightmare. And it presents with delayed symptoms. So you could correct someone's sodium really quick, and you won't know until 2 to 6 days later whether you've caused this. Really high risk factors include a serum sodium of less than 120. If they're also hypokalemic, if they have alcoholism, if they have liver disease, or that they're malnourished. And so I really like to think of this like, the alcoholic who's malnourished, has cirrhosis, and hasn't been taking care of himself. Next slide, please. So how do I go about doing this slowly? So you have to always, set your goal. So your goal is going to be about 5 to 8 milliequivalents over 24 hours, and then do things you can control. So 1, fluid restrict them, and place a Foley. Now you have accurate ins and outs, and then we can do something in the ICU called a DDAVP clamp. So DDAVP is desmopressin or ADH. Basically, it holds all, forces your kidneys to hold all the free water. Sodium issues are an issue of free water, and so now you're controlling how much the kidneys, release free water. And then you just start a hypertonic saline infusion at a low rate. I usually start at 20, and I check labs every 2 hours. If things are stable, you can space them out. And I monitor urine output very, very closely. So that's hyponatremia. Next topic I really want to touch quick about is acid-base interpretation. So this is really important because usually when your ICU patient comes up, first lab you get is the ABG. And so what's a systemic approach to doing this? 1, look at your pH. Are they acidotic or alkalotic? 2, name the primary disorder. Okay, so they're acidotic, is it respiratory or is it metabolic? 3, calculate an anion gap. Even if they're alkalotic, calculate an anion gap because that can tell you if they have a concurrent metabolic anion gap disorder. 4, calculate the delta gap. So this is your anion gap minus a normal anion gap. 5, calculate the starting bicarb. Then you'll name all the disorders you have, and then calculate the compensation. If you have only one disorder, if you have only the primary disorder, you can do a compensation calculation. And then 8, develop your differential. Next slide, please. So we can just skip to the example. So next slide, next slide, next slide, and next slide. Okay. So just an example. So let's say you have a 70-year-old male presenting from a nursing home septic shock. This is his ABG, pH 7.61, PaCO2 of 23, and that your BMP, sodium 143, potassium 3.9, chloride 98, bicarb 22. So how do I go through this systematically? So next slide, please. So I start with the pH again, right? So for this pH, 7.61, they're alkalotic. The primary disorder, well, so now I'm looking at the CO2 and the bicarb, because those are 2 main determinants. So the CO2 is low and the bicarb is about normal. So this is a respiratory alkalosis. Next step, calculate the anion gap. So this is a sodium minus your chloride minus your bicarb. In this example, it's 23, so it's elevated. So he has a concurrent anion gap metabolic acidosis. Now you calculate the delta gap. So delta gap is your anion gap minus what's a normal anion gap, 12. So 23 minus 12 is 11. Now I do what is called calculating a starting bicarb. Some people will do like a delta-delta ratio. I like to just use a starting bicarb because I can conceptualize it a little bit better. So you'll take your delta gap and then add it to what's a normal bicarb, 22, 24. So what we get is 33. So this is above a normal bicarb level. So he has an additional metabolic alkalosis. So we named the disorders. He has a respiratory alkalosis. He has an anion gap metabolic acidosis, and he has a metabolic alkalosis. Don't need to calculate compensation because it's not just a single primary disorder. In terms of differential, you want to think about each one and why these things are happening. Next slide, please. So that's an example of how to do acid-base interpretation. Just want to touch quickly about renal replacement therapy. Indications for renal replacement or dialysis is your AEIOUs, acidosis, electrolytes, usually hyperkalemia, intoxications, overload with fluid, and uremia. With uremia, it's usually if you have symptoms rather than an absolute number. They have pericarditis with a pericardial effusion, or they're encephalopathic. And then you have a couple different types. So you have your intermittent hemodialysis. This is good if you want to rapidly correct things, whether it's an electrolyte issue or a volume issue. Problem is, a lot of patients are not hemodynamically stable enough to tolerate this. So now you have CVVHD, which is continuous veno hemodialysis. So this allows for a slow correction. So the patient is hooked up to a dialysis machine and continuously, and they're able to slowly, remove volume or clear solutes. Problem with this is the patient has to be on it the whole time. They have to be continuously hooked up. Things can clot, risk for infection, and they can get hypothermic. Next slide, please. Lastly, I just want to quickly touch on Foley's. You really only have two indications for Foley's in the ICU. One is strict eyes and nose. This is probably the biggest one. These patients are sick and we want to know their ins and outs very, very closely. And the second is urinary retention. And every day you should really try to think to yourself, do I need the Foley today? Because it's a risk of both CAUDIs and also delirium. They're very, very uncomfortable. So if the patient's having urinary retention and that's why the Foley's still in, think, do I need to restart their BPH meds, or is this a patient who just has to be intermittently straight cath for a little bit? Okay, next slide, please. And I think that's it for GU.
Okay, so now we'll kind of go over endocrine. I'll try to keep this quick. Next slide, please. So glucose management in the ICU, you guys will get kind of a more detailed overview of this in the IM bootcamp. I'll just say that, glucose goes on 140 to 180 in the ICU. You want to keep a close eye on sugars in the ICU patients, even if they don't have diabetes or not on steroids. In the setting of, stress, inflammation, they can become hyperglycemic and they can also become hypoglycemic. And so it's really good to kind of keep a close eye on the sugars in the ICU. What differentiates maybe kind of hospital floor management, ICU management is that in the ICU, we can start an insulin drip for patients who are hyperglycemic. They don't necessarily even have to have DKA or HHS. If you're just having trouble getting getting control of the sugars, you can start a regular insulin drip. And then in ICU, if patients are hypoglycemic, you can also run dextrose replacement fluid up to D20 drips, which can be run through a central line. You can ask your pharmacy to even run a D50 drip if the patient is severely hypoglycemic. And they can also receive D50 ampules for hypoglycemia as well. Next slide. So the primary kind of endocrine emergencies you'll probably encounter in the ICU is like DKA. This can occur in type 1 and type 2 diabetics. The diagnosis really involves kind of three different parts. Hyperglycemia, that generally your sugars will be above 200, but it's important to know that 10% of patients actually have euglycemic DKA, so their sugars are actually normal. So you should definitely suspect this in patients who have an acidosis, an anion gap, and you don't have any other explanation for it. Generally, these occur in patients who are taking SGLT2 inhibitors, so definitely have a high suspicion for that. Patients will have a ketosis, so you can measure beta hydroxybutyrate, and that should be above 3. And they should also have a metabolic acidosis. So pH less than 7.3, bicarb is low, and they have an anion gap. It's important when patients come in with DKA or HHS that you get a good history about if there's any triggers, right? In the US, poor adherence to therapy or lack of insulin therapy is actually the most common cause, but you have to make sure you're not missing an infection, a stroke, a heart attack, pancreatitis, etc. In general, the principles of management of DKA is highly algorithmic and regimented, and different hospitals will have kind of slightly different protocols. The main thing is, starting an insulin drip. A lot of these protocols now include long-acting sub-Q insulin early, which will just reduce the time patients need to spend on an insulin drip. You'll start maintenance. You'll give them fluids up front, and you'll also start maintenance IV fluids. You have to calculate a corrected sodium to determine if they need isotonic or hypotonic maintenance IV fluids. Click next a couple more times. You want to replace their potassium pretty liberally because insulin will drive the potassium into the cells. In fact, if your potassium is less than 3.5, you can't even start an insulin drip. And then you're going to monitor the glucoses closely every 1 hour, and then you'll monitor their electrolytes and sometimes the gas every 4 hours. Next slide. HHS is different from DKA because they do not have acidosis. So these patients will be profoundly hyperglycemic, generally above 600. They will have hyperosmolarity, so their calculated serum osm will be greater than 300, and they won't have ketones, they won't have acidosis. The management of HHS is similar to DKA. They will also be started on an insulin drip. They usually are more dehydrated just because of the glucosuria that they experience, so they often will need more fluid than in DKA. The starting dose of the insulin drip is usually lower than that of DKA. It's usually half of that, so like 0.05 units per kg per hour. And the reason for that is you just don't want to drop the blood glucoses too fast to avoid large osmotic shifts and cerebral edema. Next slide. So honestly, I think the hardest part of managing these conditions for us is kind of deciding when we will, transition patients off the insulin drip. For DKA, it's when the acidosis has resolved, their gap is improved, their sugars are better, and the patient is feeling well and able to eat. For HHS, it's when, their hyperosmolarity has resolved, their urine output is good, just making sure that their volume replete and their mental status is at baseline. And that's when you can decide to start a basal bolus regimen. Sometimes people will calculate the insulin goals or needs from the insulin drip. I usually don't like to do that because their needs are often quite a lot sometimes. So I'll usually calculate kind of a total daily insulin dose for them, and then administer half of that total daily insulin dose as basal and the rest as bolus. If they already had a basal bolus regimen that was working for them prior to hospitalization, I would just resume their regimen. And it's important that you overlap the basal insulin dose with the insulin drip for 2 hours. That's just to prevent, rebound hyperglycemia and resumption of like ketosis and things like that. So this is definitely kind of a critical period in transitioning a patient off of their insulin drip. Next slide. Adrenal insufficiency may be something you might encounter in the ICU. These patients usually come in with very nonspecific symptoms: nausea, vomiting, lethargy, weakness, abdominal pain. You may note like hypoglycemia or hyponatremia and sometimes hyperkalemia on their labs. Adrenal crisis, like Dr. Wang mentioned earlier, can cause hypotension and distributive shock. The most common etiology in the US is actually due to exogenous steroids. So, if a patient has a history of being on steroids, they were recently tapered off or they ran out, this is kind of an indicator that they might be at risk for adrenal insufficiency. Getting an AM cortisol at 8 a.m. is a screening tool for this. And if that level is kind of intermediate, which is usually between 3 to 18, you can get an ACTH stimulation test, which is more like gold standard way of diagnosing adrenal insufficiency. If their AM cortisol is less than 3, it's also likely that they already have adrenal insufficiency. Ideally, you would want to get these tests before you start steroids, but of course, if it's an emergency and you have a high suspicion, you should just start the steroids. So you usually give hydrochloride 100, bolus, and then start 50 Q6 if the patients are in crisis or in shock. These patients may also need to be resuscitated with fluids as well. Next, and then eventually they'll need to be tapered to maintenance dosing with hydrocortisone. So I would definitely get endocrinology on board to help with this. Next slide. There are other endocrine emergencies. They're probably a little bit more rare, and you'll definitely have endocrinology assistants to help manage these. You may see mixed edema coma, which is just severe form of hypothyroidism. So the treatment for that is IV levothyroxine plus steroids. For thyroid storm, which is severe hyperthyroidism, you'll give them PTU or methimazole. You'll also get steroids and beta blockers. DI, which you'll see maybe in patients who have had some sort of brain injury, brain tumors, etc. You'll see these patients suddenly start putting out tons and tons of urine every hour, and it's important to monitor their sodium to make sure they're not getting dehydrated. They will probably need, intermittent dosing of DDAVP. And then patients with hypercalcemia. A lot of these patients can be managed on the floor with fluids, calcitonin, bisphosphonates, but if it's refractory, they may come to the ICU for dialysis. Next. Okay.
All right, so going over hematology in the ICU next. All right, so big things are venous thromboprophylaxis. So this is your leading cause of preventable deaths in hospitalized patients. There's a whole host of risk factors. Basically, if you look at that list, if your patient's in the ICU, they probably have at least one of them, if not more. So your patients are definitely higher risk of having unexpected clots. In terms of prevention, you have your mechanical prevention and your pharmacological. Mechanical, you have what they call SCDs, or sequential compression device, basically these squeezy things on the patient's calves. Some people like them, some people don't. If they're walking very regularly, we will sometimes leave them off, actually. Pharmacologically, you have your unfractionated heparin that's given subcutaneously. You'll often see it abbreviated as SQH. So that will either be 5,000 units every 8 hours or every 12 hours. And for your larger patients, you may end up needing 7,500 every 8 hours. So your next option is enoxaparin. The brand name is Lovenox. So a lot of patients actually prefer this, and people will prefer it because for most patients, it's just 40 milligrams every day. So single dose, you don't have to get stuck multiple times. However, it is renally cleared. So if you have a patient with kidney failure, it may or may not be a good choice. And finally, your last option is fondaparinux. I haven't used it much in my practice, but for patients who have heparin-induced thrombocytopenia, that's the alternative. Next. On the topic of heparin-induced thrombocytopenia, so you do need to have a high clinical suspicion for this. Big things are, so this calculator comes from CalcMD. If you don't have it already, highly recommend you download CalcMD, by the way. Super useful just to have it on your phone. So it's not dose dependent, and you want to ask yourself, things you want to look out for is a decrease in platelets, often falling to more than 50%. They may have signs of bleeding, and if they've had heparin exposure before. If you are suspicious for it, first things first, stop the heparin, and then you're going to send off two labs. So your PF4 or platelet factor 4, that detects IgG antibodies against the platelet factor 4 and heparin complexes, which is actually what's triggering the thrombosis in your patients. And then you'll want to also obtain a serotonin release assay, and that's your confirmatory test. That one is a send out and can take a week or so before it really comes back. Next. So last thing is really transfusions. Rule of thumb for patients is you want to keep hemoglobin greater than 7. However, there was actually a recent recommendation that just came out 2025 from American College of Cardiology and AHA that patients with acute MIs, they're actually now recommending greater than 10. I have not seen that in practice yet, so that's to be seen. But for your patients, the rate of their blood loss will greatly affect the severity of their symptoms. So someone who has been gradually losing blood can tolerate a hemoglobin of 8 or 7 much better than someone who came in hemoglobin 15 and within 6 hours hemoglobin 8. That person will be much more symptomatic. And sometimes even if their hemoglobin is not less than 7, if they are severely symptomatic, you can transfuse empirically too. In terms of your transfusions, you're going to hear a lot of different names, a lot of different things, and it comes down to you have your red, so your 1 unit packed red blood cells. You usually anticipate increasing hemoglobin by about 1 gram per deciliter for every unit you're giving. And then your whites, so that's all your plasma different factor products, and then your platelets. So in terms of plasma, your fresh frozen plasma, you have your fibrinogen, a whole host of factors. The downside is these are pretty large volumes. So for someone in cardiogenic shock, heart failure, might not be the best choice if you're trying to avoid volume. Your cryoprecipitate, much less volume, but also less factors. And then you have your prothrombin complex concentrate or PCC. So these are your 4-factor PCC. You don't usually for these we use them more to reverse anticoagulation, but you can also use it in terms of transfusion. And finally, if your patient needs platelets, if you give 1 unit platelets, your platelets are pooled through multiple donors. So if you have a patient who's either awaiting a transplant or post-transplant, you do have to be a bit more cautious and ask yourself, do they really need these products? Next. So, yep, you can just keep clicking through this. Big thing for resuscitation is this, keep clicking through. The radius of your catheter is actually going to be the biggest, what actually affects how fast you can resuscitate someone. Next. So in terms of massive transfusion protocol, so if you have a patient that's going to need a lot of blood quickly, just activate it. You can always call it off, but if you don't activate it, it can be a lot harder to get large quantities of blood quickly. So your goal is a 1-to-1-to-1 transfusion between your reds, your whites, and your platelets. However, the exact packs that will come up will be institution dependent. And if you're running a MTP, you're going to want routine labs. So if anything, set a timer every 30 minutes. You want a repeat CBC, your coagulation, arterial blood gas. You also want to look for ionized calcium and either a TEG or a ROTEM. So I'll go over those next. And then if you're running MTP, make sure your patients have really good IV access. If they don't have an arterial line, they'll probably need one because their blood pressures are going to be doing a nice little roller coaster the whole time. And last thing is you want to know when to actually stop because there are risks to everything that we're doing. General rules of thumb for MTP. I know I said keep your MAP greater than 65 earlier, but for MTPs, we actually tolerate what's called permissive hypotension. So often we aim for a MAP of 60 and that's sufficient. With your arterial blood gas, you want to keep their pH above 7.2 because everything in our body, including coagulation, likes to function within a tight pH. So if you're too far off from a normal human pH, you might actually be affecting your own clotting. So this is a case where if you need to correct for severe acidosis, giving bicarb is not the worst decision. You also want to make sure your patient's warm because being cold will severely affect your body's ability to actually clot and control bleeding. So the reason you also want ionized calcium is all your blood products contain citrate, which will chelate your calcium. And if you have low calcium, your heart can't work, your blood pressure's low. So just give calcium pretty generously. The risk of hypercalcemia is a lot less than hypocalcemia, especially in something as dynamic as an MTP. Your goal is usually you aim for a platelet greater than 50. That's normally sufficient for your patients. However, there is an exception where if they have known intracranial bleeding, then you may actually want to aim for a platelet greater than 100,000. And then in terms of fibrinogen or factor 1, you want to aim for a fibrinogen about 150 to 200, and that's a good place to be. And as mentioned earlier, with renal failure patients, you may end up wanting to give DDAVP, which increases your factor 8 and von Willebrand. Next. So TEG ROTEM, it's pretty much the same thing, institution dependent which one you'll be using. TEG, there's a pin and a cup, and with TEG, the cup oscillates while the pin stays in place. ROTEM, the pin is doing the oscillation, the cup stays in place, but it gives you essentially the same data. It's a very dynamic assessment of how's your clotting going. So this here's an example of what you'll get on a TEG. So R is your reaction time and how long it takes the clot to form. If your R is too long, give factors. And your alpha angle is the rate of your clot formation if your alpha angle is short. So that's also, you need fibrinogen, so cryo is usually a good choice for getting more fibrinogen into a patient. And then if your maximum amplitude is decreased, so that's the strength of your clot. Usually to treat, if you want a stronger clot, you're either going to give platelets or give some DDAVP at that point. And then at the very end, you'll get your lysis. So that's how fast your clot breaks down. If your clot is breaking down too much, that's when you'll give tranexamic acid or TXA or aminocaproic acid to try to slow the rate of your clot breakdown. Next. So in terms of transfusion, you can end up having reactions from it. So the two big ones to look out for actually tie back to pulmonary. So your first one is TRALI, or transfusion-related acute lung injury. So these patients will present with ARDS-like inflammatory lung issue. You're giving them a lot of blood and they suddenly get hypoxic. So big things to do, stop giving blood product, record it. And unfortunately, if your patient does develop TRALI, it is supportive care, but even with good supportive care, it's still a very, very high mortality rate. And the other one is known as TACO, or transfusion-associated circulatory overload. This TACO is definitely a bit more preventable in the sense that they will suddenly get acute hypoxic respiratory failure. However, they'll show signs of fluid overload, so it looks like more of a heart failure where you'll see JVD, etc. So for that, you just want to diurese them and get the extra fluid off. They tend to recover pretty well. And finally, if you have a patient that develops an allergy or allergic reaction, consider your patient may actually have IgA deficiency and they're reacting to the blood products. All right. And next. All right.
Okay, sounds good. So we're almost near the end, so I'll just quickly cover infectious diseases in the ICU. Next slide. So fever in the ICU, according to IAPSA and Site of Critical Care Medicine, is considered 101 degrees Fahrenheit. I still kind of like to use 100.4 because at that point, I'm trying to trend their fever curve. And honestly, looking at the fever curve is probably a little bit more important than just looking at a one-time temperature. Generally, you want to get these temperatures from kind of a core temp, so like bladder or esophageal. If they have a PA catheter, or rectal temp is generally preferred. If patients fever in the ICU, I like to get kind of a general workup and infectious workup. So blood cultures, a chest x-ray, because pneumonia is pretty common in the ICU, and a urine and urine culture. If they have a Foley, ideally you should exchange the Foley before obtaining the sample. And then of course, doing your kind of infectious workup. If the patient can talk, seeing if they have any localizing symptoms, if they're intubated or they're altered, doing a good physical exam, looking at if they have indwelling lines, if they have skin breakdown, if they have sacral ulcers. Those are all sources of possible fever. There are, of course, other non-infectious sources of fever in the ICU. I do have to say, I think you should rule out infection first, but medications can cause it. Precedex is a common culprit. Serotonin syndrome, etc. Things that we give the patient may cause fever. A thrombus is also a cause for fever, inflammatory states, and then there are central neurogenic fevers that can occur as well. Next slide. Does every fever mean I need to start antibiotics? So that is a resounding no. This can be kind of a nuanced decision, and it kind of comes with practice. I would strongly consider antibiotics if a patient is hemodynamically unstable, if they're neutropenic or severely immunocompromised, or if they have a clear source of an infection, then I would start it. But otherwise, I think if this patient is stable, it is reasonable to kind of hold off on antibiotics, do the infectious workup, and kind of see how the patient's course kind of progresses. Next slide. This is kind of just my general approach to infections. First of all, is knowing your host. Are they immunocompetent or immunocompromised? I check an HIV status in everyone that comes into the hospital. Do we have source control, right? Is this something that can be treated with antibiotics, or do we need to call surgery or IR? Did we think the patient have a pneumonia? Are they not improving? Have they now developed an abscess or empyema in case we need better source control? And then the pathogen, like are they on the appropriate antimicrobials? So this is based on culture data you have, also based on the patient's risk factors. Next slide. I'm just going to talk briefly about sepsis because you'll probably see a ton of sepsis and septic shock in the ICU. So sepsis is basically life-threatening organ dysfunction that's caused by an infection. You'll probably see a lot of septic shock, which is when the patient's hypotensive, they're requiring vasopressors, their lactic is elevated. Of note, septic shock has pretty high mortality, close to 50% in some studies. Next slide. Management of sepsis is kind of straightforward. There's a lot of like hospital bundles for managing sepsis now. Antimicrobials early is like the one thing that really has mortality benefits. The guidelines really say like getting antibiotics in within an hour. Giving fluids if the patient is hypotensive, if they can tolerate fluids, checking a lactate and trending it, and then starting vasopressors if they're still hypotensive despite fluids. Next slide. You may hear the term broad spectrum antibiotics. Your attending might say, let's start broad spectrum antibiotics, but not tell you what they want you to start. I would say this depends on several things, right? It depends on the patient's risk factors. It depends on the hospital antibiogram. Usually there's one that's actually specific for the hospital floor and one that's specific for the ICU. So that'll let you know kind of susceptibilities of pathogens to certain antimicrobials. And then obviously the type of infection. So empiric antibiotics for meningitis is very different than empiric antibiotics for an intra-abdominal infection, right? So not everyone needs meropenem and Vanc. Ceftriaxone is a really good broad spectrum antibiotic as well. I do have to say that if you want to start broad spectrum antibiotics, it's important to know what covers like the big kind of opportunistic infections we're worried about, like MRSA, Pseudomonas, what covers anaerobes, and what covers ESBL. Next. And then antibiotic de-escalation is just as important as starting antibiotics. We have to be good antibiotic stewards in the hospital. I would say once you start getting culture data back, I would narrow antibiotics as soon as possible. If you've, let's say, just started antibiotics or another team has started antibiotics, they've gotten cultures, they've been negative, and there's really no source of infection, I would consider stopping antibiotics in those patients after 48 to 72 hours. And we can always see, if the patient gets worse, we can always resume them. If, let's say, we started antibiotics for pneumonia, but we never got any culture data back, you can always narrow antibiotics based on the patient's risk factors, right? Like if someone comes in the community and they got started on cefepime, they're doing better, we can always switch them to ceftriaxone or even a PO option if there's no risk factors for Pseudomonas present. In patients who I'm starting some sort of MRSA coverage, I always like to get a MRSA NARS, and that helps me kind of decide whether I want to stop or de-escalate coverage for that. And then procalcitonin and CRP can also be considered. It's not something I've personally used because I think the procalcitonin at least is a send-out lab in the hospital I work at. But it's been shown if you trend the procalcitonin lab, if you get one, for instance, when you start the antibiotics and you get one like on the day maybe you want to consider stopping, if that level is less than 0.5 or if there's greater than 80% decrease from the peak, you can consider stopping the antibiotics. And it's been shown to at least reduce the duration patients spend on antibiotics.
Okay. All right, so I promise we're almost done. This is something that you will see usually after you present your patient. This is one of our final checklists at the very end of each patient presentation. The acronym we like to use is FAST HUGS BID. Think of it as housekeeping, just because your patients, sometimes they're so complicated and you're going to get into the nitty-gritty that you're going to forget things that, in hindsight, were kind of things that you should account for everybody. So for FAST, so you want to make sure, how are you feeding the patient? Are they NPO? If NPO, why? If not, what are they getting? Are they tolerating it? You want to make sure you address analgesia. So if they're having pain, is their pain being addressed? And if they need sedation, are they getting sedation? Because the last thing you want to do is have a patient who's intubated, ventilated, and might not have either analgesia or sedation on board, which is just no. And then, like I said earlier, high risk of developing clots. So make sure all your patients have thromboprophylaxis. And if they don't have it, make sure you have a good reason why. So if they have an active brain bleed, probably don't give them heparin at the time. So head up position, you want all your patients, especially if they're intubated, ventilated, to have their head of the bed up, usually at least 30 degrees. What they found was that actually helps with decreasing rate of ventilator-associated pneumonia, also aspiration. And it also helps optimize your lung mechanics so that, because if you're laying down versus even just slightly head up, your lungs actually can move much better and you'll actually have much easier time weaning them off the vent. So also prophylaxis, as mentioned. So in GI, your patients are at increased risk of stress ulcers and GI bleeds. So question to ask is, do they need also prophylaxis? If yes, great. If they don't need it, but they're on it, stop it, because you don't want people on more meds than what they actually need. Glycemic control, make sure that if they're hyperglycemic, they have either insulin regimen, whether it's a drip or intermittent. And if they're hypoglycemic, if they are on an insulin regimen, maybe it's time to stop it and make sure they have, whether it's dextrose, D10, D5, or even D50 available. If they're intubated, sedated, make sure you're addressing daily spontaneous breathing trials, spontaneous awakening trial. Usually you want to do these at the same time. And BID, bowel movement. When's the last time they pooped? Super, super important. Because if your patient's intubated, sedated, they can't tell you, I have not pooped in a week. So you want to make sure if they haven't had a bowel movement and there's no contraindication to it, make them poop. So, and finally, indwelling catheters. These are all infection risks. So you always want to ask yourself, what catheters do they have? Do they need them? Because if they don't need them, get them out. And finally, drug de-escalation. As you can see, everyone's on a whole host of medications. And the big thing to ask is, so polypharmacy is a huge risk, especially with your elderly patients. So do they actually need the drug? If not, get rid of it. All right, next.
And to end our presentation, just a couple words on codes. So next slide, please. So why are codes so chaotic in the hospital? Well, usually it's because one, it's a very high level of teamwork involved, usually in a very time-critical event. And you're always working with people that you've probably never met before. So there's unclear roles, lack of leadership, poor communication. Sometimes people aren't following ACLS. And then you always have the inevitable equipment issues. Next slide, please. So in the ICU, it's a little bit of a different environment because you will work with the nurses and other ancillary staff more often in a closer environment. So there's more chance of having a successful and well-run code just because you've already had some teamwork established. At least you know who everyone in the room is. So usually, I think the most important thing is really establishing clear roles. So having a code leader, usually that's going to be the fellow or attending. Compressors, have a CPR coach, make sure that they're compressing enough. And also the CPR coach will also simultaneously run the Zoll pads. Someone who's giving medications, an airway person, someone who's recording, and a runner for equipment and meds. So hopefully in the ICU, you'll see some better run codes than just on the hospital floors because of this already pre-established teamwork. Next slide, please. And lastly, I just want to touch about code status. So this is something we should really be talking about every day for all of our patients. And it's, one thing I really encourage is to talk with the patient or the family members every day and really try to get a sense of, what they want. A lot of our patients coming into the ICU, this may be the end of their life. And how do they want to end their lives, right? Do they want to go out, on 2 of norepi, full dose epi, getting compressions, or would they rather pass away peacefully? And so, have these discussions with the patients and really be specific on what they want, what they don't want. So do they want to be, intubated, or rather, would they want non-invasive? Do they want chest compressions or just medications? Do they want all these lines placed in them? A lot of people don't. And another thing I'll say is never use the term withdrawing care to the patient or the patient's family. It's too confusing of a terminology. They don't understand it. And we're never, ever taking away care from a patient. We may be switching care. So I like to use the term, we're switching to a comfort care model. So we're not focusing on aggressively treating disease anymore. We're focusing on making sure the patient's comfortable at the end of their life. And another thing is, depending on your hospital, the palliative care team can be really great. Now, you always have to ask the patient or the patient's family that you're bringing the palliative care team on board. What I always tell, families or patients is, they're not the team that's gonna, withdraw care. What they are is they can explain to you the different options on care moving forward. With that, I think that's the end of our presentation. Thank you, everybody.
Awesome. Thank you, Dr. Su, and thank you, Dr. Wu and Dr. Wang as well for preparing this presentation. And thanks to all of you for attending. We hope you found this helpful. One quick thing, as the meeting ends, you'll be prompted to fill out a feedback survey, and I just want to encourage you to take a second to fill out that feedback survey because we do truly find it helpful. In fact, we did the ICU bootcamp this year as a result of feedback that we got from the IM bootcamp last year. So again, we would really appreciate it if you took some time to fill that out. But yeah, otherwise, oh, and one other quick thing, there's a field at the bottom of the survey where you're able to input your email, and this is for if you're interested in receiving a copy of the slides. So make sure to do that as well if again, you want a copy of the slides. With that in mind, thanks again for attending and hope you all have a great day.